IEP, our nodal officer COE, Professor Prabhakar Mishra. Amar Ramkumar sir join karibe shortly, and other dignitaries present here. Director of Family Welfare will shortly join in our VC. Till then, खाली introduction दवा में चाहूँ. हमें आज ये जो कौचे समस्त जानी थी वे मैडम सर टिके म्यूट कर देता हूँ. So समस्त हमें जानी थी वा नेशनल ह्यूमन वीक हमें विगत 6 दिन धरी पालन कर सारे. Actually वर्तमान रो स्टेटस हमरो ओडिशा कॉन्टेक्स्ट जो हम कहबा हमें सेकंड हाईएस्ट इन द कंट्री इन नियोनाटल मोर्टालिटी. एवं जेते बेले हमें अंडर 5 डेथ को देखु जे तादरु 60% पाखा पाखी हे जाउची नियोनाटल डेथ एवं जेते बेले आईएमआर देखु जे सेठु 75% पर्यंत नियोनाटल मोर्टालिटी होची. एवं डिस्ट्रिक्ट अगेन डिफरेंट डिस्ट्रिक्ट रे वेरीज. तेणु आमे याको एड्रेस करिवा पई बहुत छोट छोट जिंस ऊपर आमे गुरुत्व देबा पई कहा जाउची जेमति कि जीरो सेपरेशन, देन डू नो हार्म टू द बेबी. ए सब जिंस को आखि आगे रखी कि समस्त वर्तमान सचेतन करियो पड़छि जे आमे न्यूबॉर्न मानकर जत्न केमति नबा एवं तांको केमति तांकर सर्वाइवल बढ़ेबा. तो बहुत छोट इंटरवेंशन रे आमे ता करि परिबा जेमिति कि वर्तमान रो कांसेप्ट अनुसार delayed cord clamping, then early initiation of the breastfeeding, exclusive breastfeeding, then keeping the baby warm, then sanitation and hygiene. All these things are has a great role in survival of the newborn. तो एथिपे हमरो स्टेट रो समस्त स्टॉलवर्ड्स एथरे भागन होचंती. मु बहुत धन्यवाद देबी हमरो प्रेसिडेंट आईपी इंटरेस्ट नैकरी विजय सर ये सब प्रोग्राम इन्वॉल्व होचंती एवं सब पेडियाट्रिशियन मान को मोटिवेट करचंती जे हमें केमति स्टैंडर्ड ट्रीटमेंट गाइडलाइन फॉलो करिवा. 2010 मसिया तळे जदि देखिबा पूर्वरु कोनोसी एसएनसीयू स्टेट रे नथिला. वर्तमान 44 एसएनसीयू फंक्शनल. आमे न्यूबॉर्न स्टेबलाइजेशन यूनिट मध्ये 62 टी फंक्शनल करिसे एवं सेठी हमर पेडियाट्रिशियन माने जो माने अछंती स्टेट रे से माने कार्यरत एवं क्वालिटी इंप्रूवमेंट मध्ये धीरे धीरे विभिन्न फैसिलिटी रे होउची. आगुरु आमे 78% डिस्चार्ज रेट करथिले एवं वर्तमान एटा बढ़ी कि 83% हेलानी. तथापि हमको आहुरी आगु की जुबार अछि. तो सेही उद्देश्य रे आमे विसी करूचे टू मेक यू अवेयर अबाउट डिफरेंट स्टैंडर्ड ट्रीटमेंट गाइडलाइंस. वर्तमान आम संगे मैडम डायरेक्टर फैमिली वेलफेयर डॉक्टर संयुक्ता साहू जॉइन करचंदी एवं मैडम कर लीडरशिप रे ओडिसा रे आमे न्यूबॉर्न केयर को बहुत सीरियसली आमे नै जो एवं ए 6 दिन जाका जो न्यूबॉर्न केयर वीक गला आमे 6 दिन जाका प्राय सब दिन हमरो किछि किछि एक्टिविटी आमे करिछु एवं सब बेले माने इन्वॉल्व होबे करे पे चाहिछु. सब स्टेट डिस्ट्रिक्ट रो आ पेरिफेरी रो जते स्टाफ अछन समस्त इन्वॉल्व करे पे चाहिछु. तो ई परिप्रेक्षी रे मु मैडम को कहबी टिके इनागुरल एड्रेस देबे एवं तापर हम एक्सपर्ट्स मान को पाख को जिबा टू लिसन रिगार्डिंग द न्यूबॉर्न केयर. मैडम प्लीज.
समस्त को मोर नमस्कार. नेशनल न्यूबॉर्न केयर वीक उपलक्षे हमें स्टेट तरफरु आज वर्चुअल ओरिएंटेशन प्रोग्राम करिछु. सर्विस प्रोवाइडर, प्रोग्राम ऑफिसर एवं प्रोग्राम मैनेजर मानकर जोटा पई हमको इंडियन एसोसिएशन ऑफ पेडियाट्रिक्स हमको सपोर्ट करूची एवं नेशनल नियोनाटोलॉजी फोरम से भी सपोर्ट करूची एवं तांको सपोर्ट रे आपण माने जानि थिबे देखि थिबे भी सार को डॉक्टर भैया को हमर डॉक्टर प्रभाकर मिश्रा सर को एंड डॉक्टर रामकुमार हमसाले जॉइन करिवे. तेणु से माने हमर मास्टर ट्रेनर हिसाब रे बहुत बढ़िया ट्रेनिंग प्रोग्राम रे जॉइन करिसंती एवं आपण मान को ट्रेनिंग मध्ये देइसंती. डॉक्टर मिश्रा गरता इंट्रोडक्शन दरकार नहीं. भास्टली एक्सपीरियंस प्रोफेसर रे अछंती. प्रोफेसर एंड डीन ऑफ हमारा सरदार वल्लभ भाई पटेल इंस्टीट्यूट ऑफ पेडियाट्रिक्स जोटा कटक रे अछि तार अछंती एवं सार हमको सब बेले सपोर्ट करी आछंदी तांका लीडरशिप रे आमे अगणित ट्रेनिंग प्रोग्राम डिस्ट्रिक्ट रो करि सारलुनी एवं आपण माने समस्त ए प्रोग्राम रे उपकृत होचंदी तांकर ट्रेनिंग माध्यम रे एवं डॉक्टर भुइया जे हम संगे अछंदी भुइया सर प्रेसिडेंट अछंदी इंडियन एसोसिएशन ऑफ पीडियाट्रिक ओडिशा चैप्टर रो सर भी हम संगे सब मीटिंग रे जॉइन करिसंती एवं दिग्दर्शन देउछंती आज हमर जो टॉपिक अछि ए वीक रो नेशनल न्यूबॉर्न केयर वीक रो जे रेशनल यूज ऑफ एंटीबायोटिक में करिबा एवं एंटीबायोटिक रेजिस्टेंस जोटा हमर देखा जाउची ताकू केमती प्रिवेंट करिबा हमर जो केयर अछि हेल्थ केयर इंस्टीट्यूशन ने जो हमर सब यूनिट्स अछि एनबीएसयू एसएनसीयू हमर न्यूबॉर्न केयर यूनिट जते अछि सेठी फ्रॉम द बर्थ ऑफ द बेबी before the birth of the baby I should say before the birth of the baby to discharge and after discharge at home तेणु जन्म हेबा पूर्वरु बेबी रो मदर रो केयर नबा केमिति एवं ता परे बेबी रो डिलीवरी हबो केमिति एसेप्टिक कंडीशन ने केमिति हमें वार्ड रे बेबी रहइबो केमिति कंगारू मदर केयर एंड एक्सक्लूसिव ब्रेस्ट फीडिंग एदिटा हम इंप्लीमेंट करिबा बेबी रो रेजिस्टेंस बढ़ेबा एवं सब सेंटर लेवल पर्यंत आमे जदी कोनोसी बेबी रो किछि प्रॉब्लम हे तार केमति केयर नबा एवं हमर प्रोग्राम सेटिंग कोन रहिछि ता ऊपर आज हमको प्रोफेसर मिश्रा एंड डॉक्टर भुइया एंड डॉक्टर टीवी राजकुमार हमारा राम कुमार हमको ट्रेनिंग देबे आपण माने निश्चय एटा बहुत आपण पे उपादेय साब्यस्त हो एवं आपण माने धीरे स्थिर ए ट्रेनिंग रे पार्टिसिपेट करिवे एति कि आपण को रिक्वेस्ट निजर अलगा डाइवर्सन जदी अछि ताकू दूर रे रहंतु एवं चैट बॉक्स को जाईकरी आपण को जहा अछि क्वेश्चन ताकू पुट करिवे ताकू देबे लेखि कि देबे एवं नहले एंड ऑफ द प्रेजेंटेशन आपण हाथ उठेबे हमें आपण को क्वेश्चन पचरिबो आपण क्वेश्चन दा आपण डाउट क्लियर नै परिबो किंतु दया करी मझिरे आपण इंटरप्ट करिवे नै एवं धीरे स्थिर ट्रेनिंग कंप्लीट करिया को देबे थैंक यू
इन द मीन टाइम मु यूनिसेफ को मधे बहुत धन्यवाद देवी मीना मैडम को
मीना इज देयर सॉरी दिस आई एम सॉरी रियली सॉरी
से भी लिंक देइचंदी एवं तांकर सहाय्य रे हमें ए वर्चुअल क्लास करि परछे एवं आगु मधे तांकर सपोर्ट जारी रहइबो स्टॉप करबा ना सार थैंक शेयर कर
एटा जॉब करिवे नि तो शेयर खाली करिवे स्क्रीन शेयरिंग कर दे वेलकम मीना मैम
अच्छा प्रभाकर सर now the platform is yours and your topic is number 1 first so can you share the slides Professor Mishra
I'm muted in anything.
Okay. Good afternoon. So I am doing the screen share from this side. Okay. ताकू टिके कम कर दी. लो.
You would have said. बहुत करो. हाँ जी.
That is one. Share sir. Is my screen visible?
हां सर देखा जाउची
Okay. So good afternoon everybody, all the respected faculties, our madam, revered madam Dr. Sahu, our director of family welfare, then our representative from UNICEF, who are the main organizers of this workshop webinar. So, and all the other faculties, our president of IAP State Branch, Professor Dr. B.K. Bhuya, and all the distinguished Dr. TV Ram Kumar and all other faculties and all the delegates watching this show. So should I tell in the Oriya and English both? Is it convenient? Hello.
यार बेसी ओडिया रे कोंदु इंग्लिश
हाँ
कम
बेस ओडिया अच्छा ठीक अछि. So as you know, the newborns are susceptible to infection. नवजात शिशुटी जन्म ହେଲା ପରେ ବହୁତ ରୋଗ ସଂକ୍ରମଣର ଅସୁବିଧାରେ ପଡିଥାଏ. ସେ ରୋଗ ସଂକ୍ରମଣ ରୋକିବା ପାଇଁ ଗୁରୁ ଦାୟିତ୍ୱ ରହୁଛି ଯୋଉମାନେ ସ୍ୱାସ୍ଥ୍ୟ ସେବାରେ ଅଛନ୍ତି, ଡାକ୍ତର ହଉ ବା ନର୍ସିଂ ଅଫିସର ହଉ ବା ଆପଣଙ୍କର ଯୋଉ ଏନଭାୟରନମେଣ୍ଟ ହଉ, ଡେଲିଭରି ରୁମ୍ ହଉ, ଆଉ ଆପଣଙ୍କର ଯୋଉ ପିଲାଟିକୁ ଯୋଉଠି ଯତ୍ନ ନିଆଯାଏ ନ୍ୟୁବର୍ନ କର୍ଣ୍ଣର ଆଉ ଯୋଉଠି ଏସଏନସିୟୁ ବିଭିନ୍ନ ବା ଏନବିଏସୟୁ ଯୋଉଠି ତାକୁ କେୟାର କରାଯାଏ ସେଇଠି ପିଲାଟି ପୁରା ସ୍ଟିରାଇଲ ଏନଭାୟରନମେଣ୍ଟ ରେ ମା ପେଟରେ ଥାଏ. ତେଣୁ ଆମ ମାନଙ୍କୁ ପ୍ରତ୍ୟେକ ସ୍ଟେପ ରେ ଯଦି ସାବଧାନ ହବା ତାହେଲେ ହିଁ ଆମର କଣ୍ଟ୍ରୋଲ ହେଇପାରିବ. ଆଉ ଏଗୁଡା କହୁଛନ୍ତି ହସ୍ପିଟାଲ ଆକ୍ୱାର୍ଡ ଇନଫେକ୍ସନ ବା ନୋଜୋକମିଆଲ ସେପ୍ସିସ୍. ଆମର ଡାକ୍ତରଖାନା ସେ ଜୀବାଣୁ ଦେଇଥାଏ କାରଣ ପିଲା ସ୍ଟିରାଇଲ ଏନଭାୟରନମେଣ୍ଟ ରୁ ବାହାରି ଥାଏ. ତେଣୁ ଆମର ସବୁ ଜିନିଷ ପତ୍ର ଆମେ ଯେତେ ଯାହା ବ୍ୟବହାର କରୁଛୁ ତାକୁ ଯଦି ସାବଧାନ ହେବା ତାହେଲେ ଆମେ ତାକୁ ସେ ଗୁଡିକ ପ୍ରତିରୋଧ କରିପାରିବା. ଆଉ ଥରେ ନବଜାତ ଶିଶୁଟି ଯଦି ପ୍ରିମାଚୁର ପର୍ଟିକୁଲାର ହେଇଥାଏ ବା କମ ଓଜନ ହେଇଥାଏ ତାହେଲେ ତାକୁ ଏ ରୋଗ ସଂକ୍ରମଣ ଶକ୍ତି ତାର ନଥାଏ, କହିବାକୁ ଗଲେ ବହୁତ କମ ଥାଏ. ତେଣୁ ତାକୁ ରକ୍ଷା କରିବାକୁ ହେଲେ ଏଇ ରୋଗ ସଂକ୍ରମଣରୁ ଆମକୁ ସବୁ ପ୍ରକାର ଧ୍ୟାନ ଦେବାକୁ ପଡିବ ଆଉ ସବୁ ପ୍ରକାର ପ୍ରିକସନ ନେବାକୁ ପଡିବ ଯେମିତିକି ଶିଶୁଟି ସୁସ୍ଥ ହୋଇ ବଢିବ ଆଉ ତାକୁ ସଂକ୍ରମଣ ହେବ ନାହିଁ. ତେଣୁ ସେଇଥିପାଇଁ ଥରେ ତାକୁ ସଂକ୍ରମଣ ହେଲେ ତାର କଣ ହୁଏ ନା ଆମେ ଯେତେବେଳେ ତାକୁ କୌଣସି ଗୋଟେ ଟେଷ୍ଟ କରୁଛୁ, ତାକୁ ଟିକେ ପଙ୍କ୍ଚର କରୁଛୁ, ତାକୁ ଭେନ ରେ ସାଲାଇନ ଦଉଛୁ, ସେଇ ବାଟେ ଜୀବାଣୁ ଗୁଡିକ ପଶି ଯାଆନ୍ତି. ସେଗୁଡାକ ପଶିଗଲା ପରେ ରକ୍ତରେ ଇନଫେକ୍ସନ ହେଇଯାଏ, ବ୍ଲଡ ଷ୍ଟ୍ରିମ ଇନଫେକ୍ସନ. ସେଗୁଡା ହେଇଗଲା ପରେ ତାଙ୍କର ଯେହେତୁ ରେଜିଷ୍ଟାନ୍ସ ଟୁ ଇନଫେକ୍ସନ ବା ରୋଗ ପ୍ରତିରୋଧ ଶକ୍ତି କମ ଥାଏ ତାଙ୍କୁ ସେପ୍ସିସ୍ ହୋଇଯାଏ, ଯୋଉଟା କି ଆମେ ନିଓନାଟାଲ ସେପ୍ସିସ୍ ବା ନବଜାତ ଶିଶୁର ସଂକ୍ରମଣ କହିଥାଉ. ସେଇ ସେପ୍ସିସ୍ ଟା ସେମାନଙ୍କର ବ୍ଲଡ ବ୍ରେନ ବ୍ୟାରିୟର ବି ନାହିଁ. ତେଣୁ ବେଳେବେଳେ ସେଇଟା ନିମୋନିଆ କୁ ଗତି କରେ, ବେଳେବେଳେ ସେଇଟା ବ୍ଲଡ ବ୍ରେନ ବ୍ୟାରିୟର ନଥିବା ଯୋଗୁଁ ମେନିଞ୍ଜାଇଟିସ ହୋଇଯାଏ. ଆଉ ଯୋଉଗୁଡାକ ଅତି ମାରାତ୍ମକ ରୋଗ ହୋଇଥାଏ ତାକୁ ଟ୍ରିଟମେଣ୍ଟ ମଧ୍ୟ ବହୁତ ଦିନ ଲାଗିଥାଏ, 7 ରୁ 14 ଦିନ ଲାଗିଥାଏ ନିମୋନିଆ ଟ୍ରିଟମେଣ୍ଟ. ଆଉ ମେନିଞ୍ଜାଇଟିସ ହେଇଗଲେ 14 ରୁ 21 ଦିନ ବି ଦେବାକୁ ପଡେ ଭେନରେ ଟ୍ରିଟମେଣ୍ଟ. ସେମାନଙ୍କୁ ଓରାଲ ଔଷଧ ଦେଇ ହୁଏ ନାହିଁ, ତେଣୁ ଆଇଭି ଦେଇ ରଖିବାକୁ ପଡେ. ତେଣୁ ପ୍ରତ୍ୟେକ ସ୍ଥଳରେ ଯେତେବେଳେ ଆମେ ପିଲାକୁ ହ୍ୟାଣ୍ଡେଲ କରୁଛେ, ପିଲାକୁ କୌଣସି ପ୍ରୋସିଜିଓର କରୁଛେ, ଆମକୁ ସାବଧାନ ହବାକୁ ପଡିବ. ତେଣୁ ଆମକୁ ଏଣ୍ଟ୍ରି ପଏଣ୍ଟରେ ଚେକ୍ କରିବାକୁ ପଡିବ, ଯେମିତି ରୋଗ ଜୀବାଣୁ ଏଣ୍ଟ୍ରି କରିବ ନାହିଁ ପିଲାକୁ. ଆମେ ଯେତେବେଳେ ପିଲାଟିକୁ ନେଇକରି ସ୍ପେଶାଲ ନ୍ୟୁବର୍ନ କେୟାର ୟୁନିଟରେ ରଖୁଛେ ଆମକୁ ସମସ୍ତଙ୍କୁ ସାବଧାନ ହେବାକୁ ପଡିବ. ଆଉ ସେ ଅର୍ଗାନିଜମ ଯେମିତି ପ୍ରଲିଫରେଟ କରିବନି, ବଂଶ ବୃଦ୍ଧି କରିବନି, ସେଇଟାକୁ ଦେଖିବାକୁ ପଡିବ. ଆଉ ବେବି ଟୁ ବେବି କେମିତି ସ୍ପ୍ରେଡ କରିବନି. ବେଳେବେଳେ କଣ ହୁଏ ଆପଣଙ୍କର ଏସଏନସିୟୁରେ ପ୍ରତି ବେଡରେ ଗୋଟିଏ ସ୍ଟେଥୋ ରହିବା କଥା, ପ୍ରତି ବେଡରେ ଥର୍ମୋମିଟର ଅଲଗା ରହିବା ଦରକାର, ପ୍ରତି ବେଡରେ ସ୍ୱାବ ଅଲଗା ରହିବା ଦରକାର. ଯଦି ଆପଣ ଗୋଟିଏ ସ୍ଟେଥୋରେ ସବୁ ପିଲାଙ୍କୁ ଏକ୍ସାମିନ କରିବେ ତାହେଲେ ଗୋଟେ ଇନଫେକ୍ଟେଡ ବେବିର ଜୀବାଣୁ ଯାଇକରି ଗୋଟେ ସୁସ୍ଥ ବେବି ଦେହରେ ଲାଗିଯିବ. ସେଥିପାଇଁ ପ୍ରତି ସିଫ୍ଟରେ ସେଇ ସ୍ଟେଥୋସ୍କୋପ କୁ ଆପଣଙ୍କୁ ଷ୍ଟେରିଲାଇଜ କରି ଟଙ୍ଗେଇବାକୁ ପଡିବ. ଆଉ ସେଭଳିଆ ହେଲା ମେଜରିଂ ଟେପ୍. ଆପଣ ମୁଣ୍ଡ ମାପୁଛନ୍ତି ପିଲାର, ମୁଣ୍ଡ ମାପିଲା ବେଳେ ଆପଣ ପିଲା ଯଦି ଗୋଟିଏ ଟେପ୍ ୟୁଜ କରିବେ ସେ ସଂକ୍ରମଣ ହବ. ତେଣୁ ପ୍ରତ୍ୟେକ ପିଲାର ବେଡ ପାଖେ ତାକୁ ଅଲଗା ଅଲଗା ରଖିବା ଦରକାର. ଆଉ ଗୋଟେ ଜିନିଷ ହେଲା ଆପଣଙ୍କର ଯେତେବେଳେ କୌଣସି ଟେଷ୍ଟ କରୁଛନ୍ତି ତାର ଗ୍ଲୁକୋମିଟରରେ ଗ୍ଲୁକୋଜ ଦେଖୁଛନ୍ତି, ହିଲ୍ ପ୍ରିକ୍ କରୁଛନ୍ତି, ସେଠି ଯଦି ପ୍ରିକସନ ନ ନେବେ ସେତେବେଳେ ମଧ୍ୟ ଜୀବାଣୁ ପ୍ରବେଶ କରିବ. ଆଉ ସେଥିପାଇଁ ଆମ ମାନଙ୍କୁ ପ୍ରତ୍ୟେକ ଷ୍ଟେପରେ ପ୍ରତ୍ୟେକ ଡାକ୍ତର ହଉ, ପ୍ରତ୍ୟେକ ନର୍ସ ହଉ, ନର୍ସିଂ ଅଫିସର, ମେଡିକାଲ ଅଫିସର ଠୁ ଆରମ୍ଭ କରି ଯେତେ ଇନଭଲଭ ଅଛନ୍ତି ଇନ ଦ କେୟାର ଅଫ ଦ ନ୍ୟୁବର୍ନ ବେବି ନ୍ୟୁବର୍ନ ଏରିଆ, ସେମାନଙ୍କୁ ସବୁ ଏକ୍ସଟ୍ରିମଲି ସାବଧାନ ହେବାକୁ ପଡିବ. ଆଉ କଣ କଣ କରିବାକୁ ପଡିବ ସେ ବିଷୟରେ ଆଲୋଚନା କରିବା. ତେଣୁ ପ୍ରିଭେଣ୍ଟ ଏଣ୍ଟ୍ରି ଅଫ ମାଇକ୍ରୋ, ଆମକୁ ସମସ୍ତଙ୍କୁ କ୍ଲିନ ଡେଲିଭରି କରିବାକୁ ପଡିବ, କ୍ଲିନ ରିସସିଟେସନ କରିବାକୁ ପଡିବ. ରିସସିଟେସନ ରେ ଯାହା ଯାହା ୟୁଜ କରାଯାଉଛି ଆପଣଙ୍କର ଷ୍ଟାର୍ଟିଂ ଫ୍ରମ ଆମ୍ବୁ ବ୍ୟାଗ ହେଲା ବା ଲାରିଙ୍ଗୋସ୍କୋପ ହେଲା ବା ସକ୍ସନ ହେଲା, ସବୁ ଜିନିଷ ଗୁଡାକ ପ୍ରପରଲି ଷ୍ଟେରିଲାଇଜ ହେଇ ଯଦି ରହିଥିବ ତାହେଲେ ଯାଇକରି ସେଇଟା ଆମେ କରିପାରିବା. ଆମକୁ ସମସ୍ତଙ୍କୁ ଏନଭାୟରନମେଣ୍ଟକୁ କ୍ଲିନ ରଖିବାକୁ ପଡିବ, ସରଫେସ କ୍ଲିନ ରହିବ. ପ୍ରତ୍ୟେକ ଲୋକ ହାତ ଧୋଇକିରି ଏସଏନସିୟୁ ଭିତରକୁ ପଶିବେ, ଭିତରେ ପଶିଲା ପରେ ବି ଆଉ ଥରେ ହାତ ଧୋଇବେ. ପ୍ରତ୍ୟେକ ବେବିଠୁ ଆଉ ଗୋଟେ ବେବି ଗଲାବେଳେ ଇନ ବିଟୱିନ ହ୍ୟାଣ୍ଡ ରବ୍ କରିବାକୁ ପଡିବ. ଆଉ ଆପଣଙ୍କର ଗାଉନ ଆଉ ସ୍ଲିପର ସବୁ ଅଲଗା ହବ. ଆଉ ହ୍ୟାଣ୍ଡ ୱାସିଂ ଫାସିଲିଟି ୱିଥ ଡେମୋ ଆପଣଙ୍କର ରହିବ. आउ प्रत्येक लोक जो माने एसएनसी एरिया रे काम करछन न्यूबॉर्न एरिया रे से माने नख काटिबे से माने 2 दिन करे नख ट्रिम करिवे से माने केबेले ये चूड़ी मुदी एउडा पिंदिकरी आसीबे घंटा तेणु क्लीन रहइबो एल्बो जाय हाथ धोइबे जोडा गाइडलाइन अछि हाथ हैंड वाशिंग टेक्निक धोइकरी तापरे आपण पिला को टच करिवे तापरे आ गोटे जिंस हला मोबाइल फोन रो सरफेस रे एते जीवाणु थांती जोटा कि आपणकर पायखानार पैन सहित समान तेणु आपण ताकू भी दूरे रखले भलो न्यूबॉर्न केयर एरिया को आउ ए सब जिंस प्लस एयर चेंज बेले बेले द इन्फेक्टेड एयर रहउची ताकू जदी चेंज करिवे सेटा हेइ परिबो जोटा कि हमर बेले बेले हम इन्वेस्टिगेशन करू सालाइन तयारी करू आईवी फ्लूइड तयारी करू ताकू लैमिनार फ्लो तळे सेइ सका से रखी तयारी करा जाए सो आपनकर निकु जोटा हला न्यूबॉर्न इंटेंसिव केयर यूनिट सेटा एम्ति जगह हवा दरकार जोटा कि डिलीवरी रूम रो पाखो थिबो as near and as close to the labor room area and it should be away from septic area कहना रोग जीवाणु संक्रमण हबो so always from other intensive care unit it should be away from PICU area also and controlled access and controlled environment is very important सेति पई आपन को एयर कंडीशन करिया पड़ो एयर कंडीशन फिल्टर को प्रति 7 दिन बा 15 दिन थरे सफा करिया पड़िबो आउ दरकार पड़ले एयर फिल्टर आपन यूज करि परिबे बा डिह्यूमिडिफायर यूज करि परिबे ना ट्रैफिक टू अदर एरियाज नॉट टू पास थ्रू एसएनसी तेणु एसएनसी एमि जगह हबो ता दैट शुड नॉट बी ऑन द वे to other wards or other areas to prevent infection then wash basin entry रहिबा must एटा बहुत चौड़ा हबो जेमति कि आपनकर appropriate slope रहिबो सिंक रे आउ सील्ड वॉल रहिबो अराउंड द सिंक रहिबो नले सेठी छोटो पोको सरपा रहिबे पिंपुडी रहिबे जंदा रहिबे सब प्रॉब्लम करिवे तेणु आपन को सब क्लीन रखिया पड़िबो तापरे लिक्विड सोप फैसिलिटी रहिबो हैंड ड्राइंग पई भी फैसिलिटी रहिबो ट्रैश बिन्स along the sink रहिबो आउ कोन सी जगह रे लीक करनो थिवो सेटा परफेक्टली चेक होइतो टाइम टू टाइम आउ प्रेफरेबली टू यूज RO plant water because non contaminated water is also important and warm and cold weather रे आपण से अनुसार कंट्रोल करी ताकू यूज करिवे पानी रखिवे बेसिन पई तेणु वाश बेसिन रो ए भलिया हबा दरकार आइडियल वाश बेसिन जोटा कि आपनकर क्रिस्प विशेष किछि नथिवो आउ सेउडा जहा पानी पड़ला पळै जिवो आउ जमा ही रहइबनी बा स्मेल बारिबनी ए सब पिक्चर देखैछि केमती आपण हाथ धोइबा एरिया कोन होबा दरकार केमती हैंड ड्रायर रहइबा दरकार आउ ट्रैश बिन रहइबा दरकार दैट शुड बी रेस्ट्रिक्टेड एक्सेस एंड एंटी रूम बिफोर एंट्री सेगुडा भी रहइबा दरकार एमती आइडियल करा जिबा दरकार आजिकली भी हमर एमती बहुत जगह रे आरंभ हलानी आउ आपण पूरा हाथ धोइबे एल्बो जाई हाथ धोइगिरी जिबे हैंड वाशिंग इज ए वेरी इंपोर्टेंट इन प्रिवेंशन ऑफ इन्फेक्शन कहवा कथा हला हाथ धोइबाटा परफेक्ट भाबरे करिबा दरकार आउ आपनकर हला न्यूबॉर्न रो बेबी आजिकली करा होची फैमिली सेंटर्ड केयर चित्रे एठी आपण रखिबे जेमति सफिशिएंट एरिया रखिबे फॉर सिटिंग ऑफ द मदर को भी कंफर्ट दरकार से भाबिबो जेमति निज घरे अछि आउ तार जहा एक्सेसरीज दरकार पिला पई तो तार बेड रहिबो किंतु मां पई भी जहा दरकार से ता पाखरे रहिले आपण हैंड वाशिंग पई फैसिलिटी रहइबा दरकार बेबी पई बेबी कट रहइबा दरकार ओपन केयर सिस्टम आउ एग्जामिनेशन टेबल रहइबा दरकार प्लस मां पई भी सुविधा पई दरकार एंड आल्सो तार डेली नीड मीट करिया पई बाथरूम एंड तार वॉशरूम से सब ठीक दरकार ताकू भी सफा सुतरा मेंटेन करियार आवश्यकता रहिछि एंड नो वन क्लीन्स द मोबाइल फोन बिफोर एंट्री तेणु मोबाइल फोन को आइडियली क्लीन करिया कथा नियरली 70% फोन सार कंटामिनेटेड आउ कॉमन ऑर्गेनिज्म जहां फोन रे थांदी से माने डेंजरस ऑर्गेनिज्म कोन ऑर्गेनिज्म सेगुडी को हला आपनकर सिडोमोनास स्टाफिलोकोकस से सब ऑर्गेनिज्म आ सेगुडा को अति मारात्मक जीवाणु ट्रीटमेंट करिया भारी कष्ट थरे स्टाफिलोकोकस जदी नवजात शिशुर भीतर को पसिला ताले से करिवो सेप्टिक आर्थराइटिस ओस्टियोमाइलाइटिस हाड़ पाची जीवो खंजा पाची जीवो मेनिंजाइटिस आउ मेटास्टैटिक एब्सेसेस आउ से स्टाफिलोकोकस जीवाणु को ट्रीटमेंट करिया को 4 रु 6 सप्ताह पेरेंटल एंटीबायोटिक दबा को पड़ी थाए आउ डेला सिडोमोनास ऑर्गेनिज्म भारी रेजिस्टेंट से माने ड्रग रेजिस्टेंट मल्टी ड्रग रेजिस्टेंट होंती आउ ट्रीटमेंट करिया भारी कष्ट होई पड़े आउ बेले बेले सेटा शिशुर जीवन हानि करि थाए आउ गोटे हला प्रिवेंट प्रोलिफरेशन हमर इंफ्रास्ट्रक्चर हाउसकीपिंग एमती हबो जेमती कि जीवाणु कोनसी जगह रे ग्रो करि परिबे नाही सेति पई हमकु कोन करिया पड़ो स्पेसिंग करिया पड़ो इन बिटवीन बेड एयर टर्नओवर करिया पड़िबो आ वेट एरिया को सब बेले ड्राई करिया पड़िबो वेस्ट मैनेजमेंट परफेक्टली हबो विथ लेवलिंग एंड चार्ट्स everywhere and everybody entering into the newborn care area should be trained about the waste management and the drug and medications preparations area ideally तो newborn मानकर laminar flow under कले आपण बैक्टीरिया जीवाणु रो मुक्त होई परिबे आउ डाक्टर एवं हमर नर्सिंग अफसर माने वर्क स्टेशन रे से माने से भीतर किसी खाया पीवा करिवे नाही से भीतर कोनोसी खाद्य पसियो नाही फाइल्स एंड रिपोर्ट्स रे भी जीवाणु आस्तांती तेणु ताकू दूरे की रखिबो दरकार आउ आपनकर स्पेस फॉर निकू बेड एडिक्वेट स्पेस रहिबो तार डिस्टेंस बिटवीन टू बेड्स ठीक रे 2.4 मीटर मेंटेन हबो एंड स्पेस होची 11.2 स्क्वायर मीटर हवा दरकार मैक्सिमम डिस्टेंस फ्रॉम सिंक हवा का दरकार 6 मीटर एंड मिनिमम डिस्टेंस अवे फ्रॉम सिंक इज 90 सेंटीमीटर फ्लोर शुड बी क्लीनेबल and no crevices or penetrations and it should be in wood or rubber so walls and ceiling should be washable and clean so this is an ideal area where you can move the instruments like the open care system and trolley and everything and it can be cleaned in a single go by the person who is concerned with the floor management. Then the temperature should be between 22 to 26 degree and humidity should be 30 to 60%. Air change should be 6 with 2 fresh and filter should be HEPA filter is ideal and RO water is ideal. Cold and warm should be available.
that कटि गला होदे
हाँ टिके कोन गोटे कॉल आसी कटि गला करूची करूची कोन हल्ला नेट काय कटि नेट भी अनस्टेबल बदे होची टिकेट
हमें एटू शेयर करू सर
हाँ करना कर दियंतु बेटर हबो कर दियंतु
ଆପଣ stop sharing କରିଦିଅନ୍ତୁ ରତ୍ନ ମିଶ୍ର।
हाँ मो स्टॉप कर दूची ताले फोटो कर देले सेटा हे जीवो ठीक ओके ओके हाँ
ସ୍କ୍ରିନ୍ ଟା ଟିକେ ବଡ କରନ୍ତୁ। ହଁ ଠିକ ଅଛି।
सर देखि परछनी
हाँ हाँ देखु दिसची विजिबल
ओके स्टेप 3 रे अछन
ठीक एटा 3 रे अछि ना ओके
हां
ओके ठीक 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 so most important is hand hygiene so you must thoroughly wash your hand as per the steps and the chart should be there in front of the basin and you will have to use the disposables and it should be hygienic and properly sterilized and whatever is available that should not be soiled then you nurse the patient nurse patient ratio should be maintained whatever is important and this is the chart the how to do hand washing various steps are shown how to clean and everything is trained in that so we'll have to cut the nails and remove all the bangles watch and everything and you should thoroughly wash using free flow of water and you must dry it and and then go to the to examine the patient and to take care of the patient. Next. So this is the 5 movements are shown here. What movements to do and how to do. Very good videos are there. So this can be shared in the newborn care group, and anybody will follow that. Next. So this is the yes. So these are the hand washing technique. How to show that, how to do that. Everybody should follow these things. And you must cut the nails. There should not be no nail polish on the nail because these are chemicals and they are harmful. So they should be removed while working in these areas. Okay, next. So this is the nurse patient ratio. This is shown that nurse patient ratio per shift should be 1 nurse for 3 to 4 newborns. So that is the recommended. In continuing area, in intermediate area, it should be 1 nurse for 2 to 3 newborn. Intensive care area, it is 1 nurse to 1 to 2 newborn. So that in intensive care area is our NICU area. So it is around 1 to 1 roughly. And in other areas, it can be 1 to 2 or 1 to 3. Multi-system support also like that. So in isolation room, the room should be separate and तार रहिबा दरकार तार entrance रे sink रहिबा दरकार skin with auto system रहिबा दरकार ये and place for wearing gown clean and soiled item ପାଇଁ रहिबा दरकार. Then negative pressure air with 100% exhaust should be so that all infected material can be thrown out. Then device to monitor air pressure should be रहिबा दरकार. Our appropriate seals for floor and ceiling. Then floor and ceiling रे कौन सी defect न थियो. Dirty utility room that should be presence in the facility. Then away from the caregivers passing center essentially दूरे रहिबो. Wash basin with facility for cold and warm water रहिबो. Liquid soap रहिबो. It can operate in negative pressure and there will be pedal trash bin. So pedal operated trash bin should be there. Next. So prevent entry of microbes, skin and cord care, that is very important. ଆମର particularly ବେଶୀ organism ପଶିଥାନ୍ତି ଯେତେବେଳେ ଆପଣ IV cannula ଦଉଛନ୍ତି. IV cannula ଯଦି properly seal ନ କରିବେ ତାର care ନ ନେବେ, central line ଟା very important and directly organism will enter into heart or larger vessel and ଆପଣଙ୍କର ବହୁତ ହଉଛି ଆମର ventilator associated pneumonia and other things ତାକୁ ବି prevent କରିବାକୁ ପଡିବ. Then ଯୋଉଠି ICU area ରେ NICU area ରେ ଆଉ ନ୍ୟୁଟ୍ରିସନ ବଣ୍ଡଲ ଆପଣ ଯୋଉ ଫିଡିଂ କରୁଛନ୍ତି ସେଥିରେ ବି ଆପଣଙ୍କର କେତେବେଳେ IV ଲାଇନ ଦିଆ ହଉଛି ଇଣ୍ଟ୍ରାଭେନସ୍ ଫ୍ଲୁଇଡ ଦିଆଯାଉଛି ଆପଣଙ୍କର କେତେବେଳେ ଦିଆଯାଉଛି ତାକୁ ଓରୋଗାଷ୍ଟ୍ରିକ୍ ଟ୍ୟୁବ୍ ଫିଡିଂ ଦିଆଯାଉଛି. ତେଣୁ ସେଥିରେ ସବୁ ପ୍ରିକସନ ନ ନେଲେ ଅର୍ଗାନିଜମ ବିଭିନ୍ନ ଏରିଆକୁ ବ୍ଲଡ କୁ ବା GI ଟ୍ରାକ୍ଟ କୁ ପଶିବାର ସମ୍ଭାବନା ରହୁଛି. ନେକ୍ସଟ. So this is the vernix that is protective during newborn when the baby is born. So try to remove whatever can be removed by the clothing, but don't rub it. The diaper you must apply properly so that there is minimal soiling of the bed area. And all these things are given here while preparing for IV line. You must take extra care. Do it very aseptically. First do hand washing. Then take everything in a sterile tray, kidney tray. Then you wear gloves and do it with a minimum of invasive technique and putting it together. And after doing the procedure, you will have to hand rub and or hand wash so that you clean, your hands are clean for the next preparation. While giving IV, that is very important, because when we are putting the venflon, when Neocan, particularly Neocan has got the opening, you must open it carefully and give the injection. When there are double system, then you can use one for injection, one for the saline. And this is the bundle of prevention of this neonatal sepsis, where hand hygiene, maximum barrier precaution while inserting the line, and chlorhexidine skin care you will have to use for anti-sterilization of the skin around, and you must use this line maintenance by multimodal education and training program. Check entry site for inflammation and dedicated lumen and for TPN. You will have to prepare another line for TPN and daily review the line is necessary, because these are the points of entry of organisms. So the bundle is hand hygiene, VAP care bundle is hand hygiene, endotracheal tube care, then your head elevation 30-degree, higher lateral position, stress ulcer prophylaxis, then oxidation and oral hygiene, and daily assessment of readiness to win. So the whatever period is required, you put IV line, and whenever the patient can take orally, change over. Okay, next. So this is step 5, decrease susceptibility by preventing malnutrition and encourage express breast milk use, early breastfeeding, and kangaroo mother care, and involve mother in baby care activity as early as possible, so that her confidence level becomes high and she is able to take care of the baby. And by the time we discharge from the hospital setup, she manages her baby in a better way. Next. So this is some of the areas shown how you can do. Then another area is our milk bank. As we promote breastfeeding and express breast milk, then we are producing milk banks and comprehensive lactation management units, and we are being promoted at several places. And at Sishu Bhavan also we are going to open a new one. At SCB there is also one unit, CLMC unit. So we will have to provide kangaroo mother care as close as possible. One baby, single baby, and here is twin baby. Twin baby being put in kangaroo mother care. So we'll have to send and record blood culture. We'll have to and we'll have to this written antibiotic policy. Strict use of that part is being dealt by the next speaker, Dr. T.V. Ramkumar. And we must restrict the use of reserve antibiotics, and we must have written infection control policies and hospital infection control committee, and motivation by staff leadership for nurses and dealing with epidemics. So these things are to be done when there is many times very resistant drug resistant strains. There occurs epidemic in NICU or in a sensitive area. Then we will have to go for specific measures for fumigation or cleaning, extensive cleaning, and to control the infection. Before that, the infection control team committee should review it time to time, and they should take swab and do culture and designate which areas are affected, and so that preventive steps can be taken. So these are very important in saving life and preventing neonatal sepsis in newborn babies who are highly susceptible to infection. Next. So we have almost covered most of the aspects of neonatal sepsis. So in this connection, we'll have to remember that clean is very important. Dryness is also important, because any water, any wet area is prone for infection. So another thing is that we must use disposables, that is single time use and throw, and properly we must dispose the used disposables, and we must have a bundle care for prevention of neonatal infection. So thank you very much. So we have covered the various aspects of newborn prevention of newborn sepsis. So with this, I thank again the organizers for giving me opportunity to speak on infection prevention. So I hand over the mic to organizers now.
Thank you, sir. Thank you very much for nice deliberation. Actually, एइथिरे जो कंपोनेंट्स गुडिक थिला केमिति माइक्रोब जर्नी करे को जगह रु बाहर एवं को जगह पहुंचे इन्फेक्शन हवा पूर्व जो पांचटी कथा सार सेशन नेले बहुत इंपोर्टेंट थिला हम पई एवं विशेष भाव में हमर एसएनसी और एनबीएससी रो स्टाफ मानक पई बहुत गुरुत्वपूर्ण थिला तेणु बहुत धन्यवाद सार को एवं मु आशा करी जदि क्वेश्चन किछ अछि लास्ट रे आंसर आमे खोजिबा सार जॉइन करिथिबे हम संगे जदि किसी पार्टिसिपेंट मानकर क्वेश्चन थिबा हम तार आंसर खोजिबा एवं वर्तमान मु रिक्वेस्ट करबी हमर डॉक्टर टीवी रामकुमार सर who is the associate professor in pediatrics now working at PRM Medical College Baripada Mayurbhanj sir को रिक्वेस्ट करबी सर नेक्स्ट सेशन रैशनल यूज ऑफ एंटीबायोटिक्स केमिति यूज करिवे केउ समय यूज करिवे एवं केतेबे न नेबे से विषय रे टिके आलोकपात करिवे over to Ramkumar sir. Ramkumar
Yes sir, thank you sir. So respected DFW sir, Prabhakar sir, BK Bhuiya sir, Aditya sir, Meena Som and the fellow panelists ଯେତିକି ଏଠି ଉପସ୍ଥିତ ଅଛନ୍ତି ସମସ୍ତଙ୍କୁ ଗୁଡ୍ ଆଫ୍ଟରନୁନ୍ ସେଠୁ ଯଦି ସ୍ଲାଇଡ୍ ଆରମ୍ଭ କଲେ ମୁଁ ଏଠୁ କଣ୍ଟିନ୍ୟୁ କରିବି
okay
हाँ so आमे इंट्रोडक्शन रे because what from where we have left आमे जदि सेठु देखिबा कि how can we prevent infection by सबटू most important होची early breastfeeding, encourage breast milk and use of LMU facility जोटी हे परिबो सेठी हमें करिबा and सबटू important support the mother holistically and make her comfortable so that she can give the care, restrict the IV fluids, remove the IV line as early as possible in and institution of FPC and KMC. FPC and KMC is the best form of FPC so that माने नॉट्स रो रेशियोटा हमरो सडनली जेतिकी तो अछि बहुत कम अछि सो बाय FPC and KMC हमें तांकर कामटा आउरी कम करि परिबा and very important we should give the positive feedback and encouraging the not personnel who are working already tired like nurses and staff सबु माने short रे अछंती तांकु हमें as far as possible positively हमें तांकु जति माने तांकु encourage करिबा जे positive काम करछन तांकु हमें टिके प्रशंसा करिबा so that will be the best spread to others and it will be the best motivation to them how entry color को as said hand wash hand rub cover गोटे मोबाइल ऊपर लगेबा and while you are using IV line की बाकी जिनसे जो भी प्रोसीजर करछंती use of a small bedside हमरो जो bedside almirah जोटा थाए that is movable so usually हमें सेंतियारो easily मिल जिवो कि बट ट्रॉली मिल जिवो which can be used for keeping the sterile objects like IV line देलालको हमें जेमती से जोतरे पिला स्विच ग्रीन कलर ताकू जेती पर्यंत टच करिबा नाही okay so with this now I am going to the topic rational use of antibiotics in the newborn the first line is that हमें rational use of antibiotics 90% talk देवार अछि कि probably antibiotics are not required so that is the most important message which from starting hobo so maximum time मोर जो message ता रहइबो that not to use antibiotics and जदि भी use करछु we should follow a written policy next so antimicrobial भितरे हमरो antibiotic आसु antiviral आसु antifungal आसु so in these all kind there are many institutions where we have to also use the antifungals especially हमरो extremely low birth weight infants there are some selected situations where हमरो candid in urine आसिलाल को हमें जो antifungal institute करछो so these also so recognition is very important critical points but it is not that कि हमें prophylactically समस्त को कौन सी मेडिसिन दे दबटा ठीक नहीं है so we have to recognize that antimicrobial resistance एपे ए वर्षर जो टॉपिक टा जो अछि they include the antibiotic antiviral antifungal next so we see why do we start actually antibiotics in SNCU or any place one we feel that the baby is sick okay and remember every sick baby or every sickness is not due to sepsis that is the fundamental number 2 baby bahut choto achi so small or very small baby extremely preterm so they will be giving Third, some say not a valuable baby, IVF baby. So the gynec obstetricians manankar pressure thibo ki this is a very valuable baby, sir. Valuable baby mane kon? See, this is a it is the worst term which is ever possible. For us, any baby who is getting admitted into SNCU is valuable. So every life is valuable. So these word valuable, we should totally discourage from them. Then the fourth one is the own relative or some known to patient. So the asijibo, then we say that kare nijoro helalku are tike de deba kai ki risk naba. So in all the situations, everyone, many of us know the real cause is probably not sepsis, but we start antibiotics because there is a pressure or fear of losing the baby. This dar will cause us to make errors. So we should first able to control our that urgent fear of losing the baby, and we should start rationally. Next. So in this slide, now we will see some. Next. So you can see in this slide, now I can ask any of the nurses who are there, can tell in the you can just if possible, can you want to start antibiotic or not? Like if the baby has come not feeding well, so in all the baby, any baby not feeding well, will you start an antibiotic? So the answer should be no. It is multifactorial. Whether it is due to the sickness of the baby, some the gestation is not enough, so that is the reason, or the mothers there is a problem. So probably I know that everyone cannot unmute and speak, so that's why I cannot ask you. So I'm just discussing this, okay? But so definitely not feeding well is not sufficient to start an antibiotic. It is one of the symptom. Number two, birth asphyxia. Birth asphyxia, very serious baby. Baby may die, but baby does not require an antibiotic. Convulsion. In convulsion, there are so many causes of convulsion. Birth asphyxia leading to HIE, hypocalcemia, hypoglycemia, then in all these things. Then there is a special in even to jaundice. Then bilirubin-induced neurological damage. Then a small part is played by the sepsis and the meningitis, jaundice, pathological jaundice. There are units where even every baby who is coming with jaundice also you started an antibiotic. So that is very dangerous. Okay, so I am talking about whenever I am discussing that, I am telling that these are been starting. So it does not mean that every unit is starting, but there are some small units which are there still in this state where they have the they are starting. So that is why I said this very low birth weight. So very low birth weight also, just the weight is not the criteria for starting the antibiotic. Even the baby can be extremely low birth weight also. 700, 800 grams. Baby does not require an antibiotic. Abdominal distension. Even just some lack of sometimes just some mild degree of feed intolerance, baby not pass through, that can be the reason for abdominal distension, may not be obvious sepsis. So no. Anomalies like tracheostomal fistula, cleft lip, cleft palate, any such anomalies which are there, they are also not the indication of antibiotics. Skin infection. Like skin infection, definitely we will discuss regarding the skin infection and umbilical discharge separately. Then comes the MSL and MS. So remember, meconium in a newborn is sterile. So even if the baby is aspirating meconium, it does not warrant the use of antibiotics. Hypothermia and hyperthermia in itself can be a sign of sepsis, but environmental causes, but lack of keeping the baby in a proper atmosphere can lead to these conditions, and simple correction can avoid a lot of antibiotic misuse. Diarrhea in most of the cases in the newborn is because of transitional stools, and there are many places where the either they are given maybe like Colicate drops, or sometimes they are given some probiotics, and even some places they will be given antibiotics also. And vomiting, diarrhea, these all are non-specific symptoms, and these all by in isolation do not correlate with sepsis. Next. So rational use means we should know what identify the risk factors for the possible sepsis, clinical features we should identify, then diagnosis of sepsis by screening, and then we have to confirm. Then finally comes this treatment, which is a small part. And next. So what are the risk factors for sepsis? We should know that there are two categories, superficial and that is superficial local infection and the systemic infection. Systemic infection is called as sepsis. Next. For superficial omphalitis, redness or induration around the umbilicus or pus staining from it, that is regarded as a local infection. So just clean with antiseptics followed by application of mupirocin or half strength, 0.5% is full strength gentian valet 4 times daily. Okay, if there is severe, then redness is extending more than 1 centimeter of the surrounding tissue, we should think of sepsis. We can give antibiotics. I have written here precisely oral amoxicillin for 5 days because before 2022, the guideline of IMCI was to place this category in the possible serious bacterial infection, but now this has been moved into local bacterial infection. Next. Second is the conjunctivitis. There are different causes, chemical, chlamydia, gonorrhea, though it is technically rare. So most of the conjunctivitis which happen in the newborn is because of the amniotic fluid that enters and just irritates the eye. And by simple cleaning the eye from medial to lateral using separate cotton, sterile cotton, that is sufficient. Neonatal pustules, pustular melanosis, again the local application of mupirocin and the oral amoxicillin for 5 days. Next. Neonatal sepsis, generalized, okay, so it may be localized to lungs, meninges, bones or joints. So early onset sepsis may get a risk factor because this will, if there are risk factors, then we can start the prophylactic and the antibiotics, and then if the sepsis screen comes negative, we can stop, so that there should be an option. So for early onset sepsis, that is less than 72 hours, the risk factors include the flora from the maternal genital tract and the delivery area. So risk factors are prolonged rupture of membrane more than 18 hours, foul smelling liquor, multiple PV examination or the more than 2, maternal fever, prolonged labor. So usually the baby presents with the pneumonia. Organisms in developing nations, both early onset and late onset, the organisms are same, which is the E. coli, Klebsiella, Staphylococcus aureus. In developed, there are variable. Okay. Yes. Next. In the late onset sepsis that occurs more than 72 hours, the risk factors include the external environment if the baby is in the community, and if the baby is admitted in the hospital, that is the hospital environment. So here the poor hand hygiene, lack of breastfeeding, poor cord care, superficial infections, IV fluids, skin disruption, bottle feeding, aspiration of it. So these all will go and contribute. Clinical features will be sepsis, pneumonia, meningitis. Organisms, as previously mentioned, Klebsiella. In our context, most of the cases we get Klebsiella and Staph aureus, and the others are rare. Next. Clinical features of neonatal sepsis. They are definitely vague, ill-defined symptoms. High index of suspicion is required, and the characteristic, if any baby is well, we know if the baby is maintaining temperature, maintaining airway. Airway means the baby is having no sound or no noise, no secretion. So this is characteristic of good airway. Good breathing. So work of breathing is normal. Good circulation. So CFT is less than 3 seconds and the heart rate is less than 160. And baby is having C, means conscious and alert activity. Feeding is good and the baby is alert. Khatam. So this means the baby is good. Then the early signs are altered feeding behavior. A baby which was previously feeding well, poor feeding, refusal to suck, lethargy, unresponsiveness, poor cry, irritability, apneic spells, fast breathing, chest indrawing, grunting. In GI, like vomiting, abdominal distension, mucosal bleeding. Then in if it is severe NEC, kidney renal failure, congestive heart failure, scleroderma. So there is a lot of spectrum of things which are there, and in isolation, a single symptom by itself should not tell that the probability is sepsis. So we should combine the things. Next. As per the IMNCR, now you can see that 0 to 2 months, which is a part, obviously newborn are included in it, So any one of more of the following signs, like not able to feed at all or not feeding well, convulsion, fast within 60 breaths per minute, and especially important is that this is less than 7 days, only less than 7 days. Okay, if the same fast breathing, if it is above the 7 days, okay, then it might be considered as pneumonia. Here it is severe sepsis, severe chest indrawing, auxiliary temperature very low or very high, movement only when stimulated or no movement at all, then you should think that probably, next slide, the baby is suffering from possible serial bacterial infection, or it can be meningitis also. So if this baby is in the community, then give anticonvulsant, then first dose of IM MP Genta, then treat to prevent low blood sugar. So keep TABC along the way and refer urgently to the hospital. So the message here is that the diagnosis is called as possible serious bacterial infection or very severe disease. The name is PSBI or very severe disease. So in that level where they are sending, they have no capacity to differentiate various things. So for them, they are giving first dose of antibiotics. So if at all there is a treatable cause, that is treated. But once the baby reaches to the referred center, there the clinician has to use his clinical acumen and other tests to classify. The other one which I said is the fast breathing, 60 isolated fast breathing is regarded as pneumonia. So it is not a PSBI, it is pneumonia, in which you can just, if the baby is not having low weight for Hess or any severe classification, we can complete the oral amoxicillin for 7 days, and this oral amoxicillin includes the 30 mg per kg per day for 7 days. So in other cases, we are giving 25 mg per kg per dose BD for 5 days. Here you are giving 30 mg per kg per dose BD for 7 days. Next. So sepsis screen is very vital once the baby reaches. So more than 2 or more should be regarded as a positive screen, and most important is that negative predictive value of 2 screen 12 to 24 apart is very high. So positive say jada, negative is more important. So TLC less than 5000, ANC less than 1800, IT ratio, CRP, micro SR, out of which again the IT ratio, micro SR are very difficult in many of the centers, not done. So but 3 TLC, ANC, CRP are done in almost all the centers where you are doing CPC and CRP. So kindly respect these 3 values and treat accordingly. Next. Approach to neonatal sepsis rate, very important is that once we are suspecting sepsis, you can start antibiotic if the screen is positive or if there are a lot of risk factors, but kindly send a blood culture in the periphery. In higher centers, we can send the vector and the blood culture. Remember, in many of the centers, even our blood culture is being done because of Nidan scheme and other PP schemes. So kindly send some samples, because each hospital needs an antibiogram of its own. So that is very, very critical. So you can see even in very high NICUs where there are so sick babies, the organisms in itself like Acinetobacter, Pseudomonas, the incidence is very high. So their first choice of antibiotic is different from what we use. Okay, so kindly and remember, whatever preventive measures you can do, whatever treatment measures you can do, these all are very, very nicely can be done in the lower level rather than the medical college, in the centers where are so much overcrowding. In these places it will be much difficult, but in a place where there will be one baby in a bed and you are having more freedom to do such things, and kindly send blood cultures and build your antibiogram. That is vital. Next. So now the treatment of any baby coming to the supportive care, and then a small part always by the antibiotics. And always remember, antibiotics are the supportive care always ensures the TABC and the glucose, ensuring optimal nutrition. So as I said, start enteral feeding. Do not try to keep the baby NPO. And please, if the gut is well, even a child with pneumonia or some sepsis can also receive the nicely the feeds through orogastric tube. So at least don't deprive the child of the nutrition, and as early as possible try to increase the quota of feeds. Any baby who is above 1.2 to 1.3 kg, straight away give full feeding. Please do the abdominal girth, and that's enough. The incidence of necrotizing enterocolitis or feed intolerance between the groups which have started full feeds, matlab more than 1.2 kg, and those who are giving slowly, the incidence is almost same. So we need to fear less, and we need to start enteral feed, because this is the way by which we will not put lines. Okay, so we will be very happy with that, and please encourage the mother, support her to bring milk. Antibiotics always the choice, as in our center when we did our most of the organisms, even like Klebsiella and the Staph aureus, which is growing in which has grown in our place, is universally almost sensitive to amikacin. So there it was registered. So some were resistant to cefotaxime, some were not. But amikacin, 90% se zyada amikacin was sensitive. Even this, so we will prefer to use the amikacin. There are centers in which netilmycin is sensitive. So some people in some centers have even started netilmycin as a solo antibiotic as the choice to start with. Okay, and as per the culture report they will change. But for our guideline, we will prefer to start with in any neonatal sepsis ampicillin and gentamicin. So this is very very vital, and respect. And you see that the most of the medications which are given like this, they are working very very nicely. 50 mg per kg per dose of ampicillin 12 hourly to previous slide. Yes, so that one, and gentamicin also 2.5 mg per kg per dose BD or 5 mg per kg per dose OD can be given. And if the suspicion of meningitis is there, so instead of ampicillin, cefotaxime can be added, and in place of genta you can give amikacin. So if we in our place, if we are suspecting meningitis, we start with cefotaxime or amikacin, and if we are not suspecting meningitis, we are doing cefotaxime and gentamicin. And once we see that within 40 to 70 hours there is worsening of symptoms, or there is some other, then we go for the second line, which is adding piperacillin tazobactam while omitting cefotaxime, and continuing amikacin. And if you are suspecting the condition as meningitis, then we will use meropenem. Again, there is a point which I would like to make, is that many places where there is some abdominal distension, they straight away would like to include the metronidazole. Okay, metronidazole they like to give. Okay, if the choice of antibiotic of adding metronidazole is good, if the baby is receiving ampicenta or cefotaxime amikacin, but if you are giving pipjo or piperacillin tazobactam or meropenem, so there is no necessity of adding metronidazole, because both piperacillin tazobactam and the meropenem have got good anaerobic coverage. So adding metronidazole to this combination will not provide further help. So always we need to look at the these conditions, and especially as per the gestation of the baby and the number of days, that is less than 7 days, more than 7 days. If fairly nice guidelines have been given to the in the FBNC book and also in the NBSU book, so that can be very easily followed. Okay, and those who are working in medical colleges and higher centers, they follow the neofax guidelines, where they are given in much more detail. The duration of the antibiotics is around 10 to 14 days. If there is a pneumonia, UTI without sepsis, the guideline says you give for 7 to 10 days. Also in culture positive proven sepsis, you can give around like 10 to 14 days. And if there is meningitis, or there is like septic arthritis, in such cases we can prolong the antibiotics to 3 weeks. Sometimes where there is a severe gram negative hospital acquired infection, so we need to demonstrate that the culture has become negative in some cases. But otherwise these are the fair guidelines. So whatever it may be, in most of the cases where we are starting the antibiotics for our safe good feeling, maybe we presume that because we have not taken good care in the asepsis, so probably antibiotic is like the shield for that, covering those defects. Never, never and never. So this is what antibiotics cannot cover the defects what we leave in the hand hygiene care. So we need to again stick to the basics: hand hygiene, hand wash, good early enteral nutrition, involvement of the mother and other caregiver in the care, that is the family participation care, so that and you can form the the doctors and nurses can work together, that they can in where the antibiotic use is very high, they can start looking that okay, from 1.5 kg onwards or 1.2 to 1.5 I will not give antibiotic. Okay, you can start doing that, you start doing that exercise for some babies, and you see that the rate of the worsening or the death will be no different. So in this way you yourself can prove. So this is what is called as like a POCI model, or a point of care quality improvement. You can improve yourself, and whenever there is incidence of such sepsis and other things, do not try to pinpoint each other and don't try to disgrace the staff and yourself or the sweepers, because they're already working and tirelessly. So we need something to improve ourselves holistically, and we can do some minor changes in our mindset and our work, and we can give some positive feedback in which they can take it easily without criticism. Then probably the change which will come might be slow, but it will last much longer. Next. So as I said, because it is all the fear which is there, not so डर. So डर से मत डरो, क्योंकि डर के आगे जीत है. And definitely we will we can, that jeet is that we can preserve the antibiotics for our future generation, so that they will be preserved. But if we go on using the antibiotics, probably we might harm this baby due to the side effects of the drug, and in future development of resistant organisms, and in future the antimicrobial will be historical. So we need to then will be nowhere. Thank you.
Thank you very much, Dr. Ramkumar. Really, your speech was very excellent. I think that will give learning points for all the service providers in SNSU. Now, next speaker is our Vijay Kumar Bhaiya sir, President IAP. He has got very nice presentation on rational use of prescription, how to prescribe medicines, because ଏବେ ଯେମିତି ଆମେ rational use of antibiotics କଥା ହଉଛେ, ସେମିତି prescription ରେ ମଧ୍ୟ ଆମର ବହୁତ ଗ୍ୟାପ୍ ରହୁଛି। ପ୍ରେସକ୍ରିପସନ ରେ ଗ୍ୟାପ୍ ରହିଲେ ବହୁତ ଯାହା ତ ପେସେଣ୍ଟ ସଫର କରିବେ ବା ମେଡିସିନ ଦୋକାନୀ ସଫର କରିବେ ଏସବୁ ହବ, କିନ୍ତୁ ତା ସହିତ ମେଡିକାଲ ଲିଗାଲି ମଧ୍ୟ we are responsible as a doctor. So ସେଥିପାଇଁ ସାର୍ ମୁଁ ରିକ୍ୱେଷ୍ଟ କରିବି ସାର୍ ତା ଉପରେ ଟିକେ ଆଲୋକପାତ କରିବେ ଯେ how to write proper prescription. ସାର୍ over to you sir. ମୁଁ ସ୍କ୍ରିନ୍ ସେୟାର କରି ଦଉଛି
Thank you. Share my slides.
Yes, sir.
Good afternoon, everybody. Director Family Welfare, Dr. Sanjukta Sahu. Dr. Aditya Mahapatra, Additional Director. Am I audible? Am I audible?
Yes, sir.
Yes, sir.
Then the other faculties, Dr. Prabhakar Mishra, Dr. Minash Om, Dr. T.V. Ram Kumar, all the participants, which includes also probably many health administrators. I'm thankful to the Director of Family Welfare for giving this opportunity to me to talk today.
Is it visible?
Yeah. Thank you.
Sure.
See, my topic today is legible and rational prescription, a comprehensive approach for optimal patient care. As you'll be seeing, this topic is out of sync so far as today is concerned, because we are observing the newborn week and we are discussing about the newborn. But the rational antibiotic therapy is only a part of a rational prescription. So it has got some relevance. I gave this talk in the recently concluded Odisha State Pediatric Conference. And the additional director, who happens to be a pediatrician, also heard this talk, and he wanted me to give this talk today because it has got a lot of relevance so far as today's situation is concerned. Many of you might have heard this topic in the conference, so I request to those who have heard already to bear with me. This not only concerns pediatrics. This today's talk not only concerns about the pediatricians, neonatologists, but also concerns all branches of medicine. Please hold on to that topic. Initial. It concerns all branches of medicine, whether you are a medicine, surgery, gynecologists, dermatology, or any branch of medicines. It concerns all doctors and all health administrators. As you know, legible and rational prescription is nowadays, you might have seen many prescriptions are legible and irrational. This is really a matter of concern. And the purpose of my presentation is to give you a food for thought, actually, what we can do to improve on this. As you know, this prescription has got two components, legible and rational prescription. Either if your prescription is not legible, there's no meaning if you give a rational prescription because nobody can read it. Even if your prescription is legible and prescription is irrational, also it carries no meaning because patient is not going to benefit. But your prescription has to be legible and rational. That is good for everybody. It is good for the patient. But if it is illegible and irrational, that is the worst thing that can happen to the patient and the society. So with these few words, I am going to present my talk, and I hope it will have a lot of food for thought for all of you. Next. Next, please. What is a legible prescription? Legible prescription means a prescription or medication order issued by a practitioner, licensed by law, is capable of being read and understood by the pharmacist, nurses, and other practitioners, in addition to the patients or relatives. Next. What is the law pertaining to legible prescription? Clause 1.5 of IMC, Professional Conduct, Etiquette and Ethics Regulation 2002 prescribes that every physician should prescribe drugs with generic names legibly and preferably in capital letters, and he or she shall ensure that there is a rational prescription and use of drugs. Not only there is an IMC provision for this, I think already there is a guideline for the government as well as from the court also regarding legibility of prescription. Next. These are some of the examples I have collected. This. How can the prescription be illegible? See, on the left side, you can possibly say something written in English. But on the right side, you do not know whether it is English, whether it is Greek or Latin. So this is the legibility of this prescription. Next. These are few examples I will show you next. This is again some prescriptions where, no, please, the previous one. Here on the left side, possibly you cannot read anything. On the right side, you can possibly read 50% of the prescription. Next. This is a discharge card of a pediatric hospital where the discharge card, this is illegible. Once it is illegible, you do not know whether it is rational or it is irrational. Next. So what is a rational prescription? By definition, rational prescribing describes a logical approach that includes making a diagnosis based on history and physical examination, if necessary with investigations. You can make a differential diagnosis if obvious the diagnosis is not there, establish the goal of therapy, select most appropriate treatment, and monitor the effects of treatment. Next. In a recent ICMR study of 2019 to 2020, which has been published in Indian Journal of Medical Research, which includes all hospitals all over India, including tertiary care hospitals of India. 45% of the prescriptions, that means out of 4,838 prescriptions that were audited, 2,171 were incomplete prescriptions. 10% of them in tertiary care hospital, like Sabdarjak and All India Institute of Medical Science, had unacceptable deviation, which means there is inappropriate prescription of medicines and more than one diagnosis. Next. What are the components of rational prescriptions? Which includes prescriber's name, qualification, registration number, and contact information, date of prescription, patient's name, registration number, age, sex, weight, and height. History and physical examination, diagnosis and the differential diagnosis, medication, follow-up, signature. See, out of these, if you see first three up to patient's name, nowadays I find the reception already gives a computerized description to you where everything is written. The doctor is to start writing from history and physical examination. Next. History taking is very, very vital. What is the chief complaint? History of present illness, past medical history, family history, immunization history. For a pediatrician, it is very, very important to take the family history and immunization history. Next. Physical examination includes a thorough physical examination, including general physical examination, systemic examination, and identifying physical signs related to the chief complaint. Next. Diagnosis is mainly based on history and physical examination. In fact, if you take a thorough history and do a good physical examination, more than 80% of the cases can be diagnosed without any further investigations. But if you still cannot diagnose, then you can go for investigation to make a complete diagnosis. Next. So there are 5 R or rights of medications. The right patient, identify the patient's need for medicine. That's the right drugs, choosing the most appropriate medicine, right dose, right route of administration, and the right time of administration, determining the appropriate timing, frequency, duration, and medication. And the 6th right I can include is the right to refuse. Next. Why it is important in pediatric practice? Because pediatric has got a unique considerations, difference in pharmacokinetics and pharmacodynamics, age and weight specific dose calculation, age specific adverse effects. Next. Challenges in pediatric prescribing. These are limited clinical trials, in some cases leading to off-label use, complex dose calculations based on weight and age, difficulty in medicine administration. Next. Pharmacokinetics in children vary. Absorption varies with age, gut motility, and gastric pH. Distribution influenced by body water and fat composition. Metabolism, immature liver enzyme in infants, which hampers metabolism of the drug. And excretion of the drug in the kidney also because of the immaturity of the kidney in small infants. Next. What is the importance of follow-up advice? Monitoring treatment efficacy and side effects, ensuring patient adherence, warning signs to watch for, and schedule for follow-up visits. Next. These are some of the examples of irrational prescriptions. If you see the prescription on the left side, which has got the name, age, 6 months, and male, you do not have a weight mentioned, no diagnosis mentioned, fever cough for 3 days, no diagnosis, no physical examination. And the antibiotic, first is the antibiotic, Teximo, which is a cefixime. From the history, as you know, there is a fever, cough, and cold. That means the possibility of viral fever where the antibiotic is not warranted. Even if antibiotic is warranted, this is not the proper antibiotic because this is cefixime, which is not indicated in upper respiratory infections. Syrup PCM, 1-TSF, SOS. 1-TSF means what? The concentration of the drug is not mentioned, whether it is 100 milligram or 250 milligram. 1-TSF is how much? Then syrup something, half TSF, TDS, half TSF, BD. Actually, the prescription should not be written in this way. The strength of the drug and how many times to be taken, when to be taken, dose should be proper. And see, this prescription is absolutely irrational. Next. This is another prescription you see. There is no complaint not written, examination finding not written, diagnosis not written. Straight the doctor goes for advice. What is the advice? PCM, BD. What does it mean? What PCM? What is the strength? And when to take BD? See, normally fever comes very frequently, every 4 to 6 hours. Here the doctor writes BD. Actually, BD, TDS, QID should be avoided in a prescription. The patients do not follow this. Next is syrup azithromycin. Again, strength is not mentioned, whether it is 100 milligram, 200 milligram, and BD doses. Salbutamol. Again, the strength not written, it is BD. So this sort of prescription causes more harm to the patient than doing any good. This doesn't contain the diagnosis, medicine strength not mentioned, dose duration missing. And this is not a single prescription. You find many of these prescriptions like this. Next. So this is a prescription where I couldn't actually read actually what is this something written. What I could know from the CT scan report is patient had a fall actually. This is a child who is 8 kg, patient had a fall, has been advised for CT scan. CT scan report is normal. I think the patient, any patient comes with a fall, a thorough clinical exam is necessary with history and physical exams. In most of the cases, actually not require a CT scan. If you do a thorough and physical examination, you can advise to the patient, if this happens in next 48 hours, please come back. Because advising a CT scan not only involves money, but also involves radiation. So not that any patient comes to you with fall, you advise a CT scan. This is not done actually, not very rational. This is a grossly irrational way of treatment. Next. This again a series of prescriptions which are absolutely irrational. Patient comes in the morning with gastroenteritis, you give some medicine. Then after a few hours, you admit this patient. Then you start giving fluid, give amikacin and ceftriaxone. And in the evening, the patient is discharged on request. Next. Next. No, previous prescription, can I have it? The previous one? Yeah. This on the left side, you see diagnosis written as APD, acid peptic disease, which normally you do not find in a child. Pantoprazole and something else written. On the right side, diagnosis is URI, but the patient is then written Defi lotion, Defi soap, and Defi and everything except the prescription of URI. Next. This is again another prescription of irrational prescription. Okay, next. Proper documentation and communication is important. Accurate documentation regarding history, examination findings, diagnosis, and prescription detail is mandatory, which is missing as I showed you in all of the prescriptions. There is an importance also of informed consent. Next. Adverse drug reaction is very, very important. Type of adverse drug reaction the patient has, monitor and report. Minimize the risk by explaining the patient regarding the adverse drug reaction of the drug that you have prescribed. Next. Role of healthcare providers. The need for interdisciplinary approach if you are unable to diagnose a case properly. Collaboration among doctors, nurses, and pharmacists for proper implementation of the order. Continuing education is very, very important because so that your knowledge gets updated. Keeping up to date with latest guidelines and research. That only lead on to a proper and rational prescriptions. Next. Parental involvement in pediatric practice is very, very important. Educating parents regarding the disease, proper administration of medicines, and abuse of antibiotics. See, most of the time, the child refuses to take medicine, how to give medicine, what to do, all these things to be explained. Recognizing the side effects. Patients have to warn that these might be the side effects. Please report if you get the side effects. Involving in the treatment for adherence of treatment and follow-up of treatment. So parental participation in pediatric practice is very, very important. Unless you explain to the patient that it's no meaning in just giving a prescription and tell the patient to go away. Next. So summary and take-home points, importance of legible and rational prescriptions. As I as I have shown you, there is a definite need for eligible and rational prescriptions. And there is a food for thought for everybody, in fact. If our prescription is not eligible and rational, then that the patients and the society suffers. So how this can be done? There is a need for sensitization to the doctors. If the sensitization fails, then what? Then there may be some accountability. There may be some law. Many times we have got laws which are not implemented. But this is a very, very serious issue that health administrations and all the doctors should take into account. Prescription audit. One should actually self-audit the prescription. Once you write the prescription, you yourself ask, is my prescription legible? Then ask if my prescription is rational, whether what I have written is correct. If you ask these two questions to yourself, then possibly in the next patient you will give a better prescriptions. If you fail to do this, then the reverse way is, nowadays the patients have become very, very, aware of their rights and responsibilities. Many of them are also become Google doctors. So time will come, the patient will ask you, doctor, your prescription is not legible. Please give me a good prescription. Or he might ask you, if you are giving an antibiotic in a case of cough and cold, he might ask you, doctor, do I really need an antibiotic? So to save your face, you can say, yes, we need an antibiotic. But for the next person, you will definitely think that, yes, I should not use an antibiotic for a mere cough and cold. So these are some of the things that actually starts me, and I want to put this in your mind so that one should think about this, what can be done. Because these sort of things are not a very sort of occasional occurrence. Majority of the cases this happens. Prescriptions are not only illegible, but also highly irrational. So comprehensive approach, including history, physical examination, diagnosis, medication, and follow-up is very important. Ongoing need for vigilance and education. Next. So see the prescriptions. Our prescription involves only the capsules and medicines, or the doctor is busy writing medicines. Thank you very much. With this, I stop my deliberation. Thank you again for giving me this opportunity.
Thank you very much for your nice deliberation. Actually, बहुत भलो थिला आपनकर rational prescription केमि हम लिखिबा mainly हमर youngster मन पई. Next move within 10 to 15 minutes विशेष भाव में कहबी prescription audit विषय रे केना this is a program again in the quality improvement program हम जो quality cell कहउचे कायकल्प मुस्कान लक्ष्य ये सब रे prescription audit is also a part of this program. So हमको से विषय जानिया दरकार विशेष भाव में हमर एडमिनिस्ट्रेटर माने मैनेजर माने ए सब जिंस जानिया दरकार so that हमें properly करि परिबा जे prescription audit मध्ये time to time करि परिबा. So मु से विषय के कहबी केना this is a program हमको जानियो गुडियो आगु मध्ये आपण prescription audit करिवे केतरा जगह रे recent न तो 2 वर्ष भीतर मु जानिबारे हमरो मानसी पंडा मैडम जेतले एचओडी कम्युनिटी मेडिसिन थिले बलांगीर रे से प्रेस्क्रिप्शन ऑडिट ऑन डायरिया करथिले नुआपड़ा बलांगीर जिल्ला रे दैट वाज हाईली एप्रिशिएटेड बाय मिशन डायरेक्टर सेथि पे हमकु मध्ये निज निज इंस्टीट्यूशन रो प्रेस्क्रिप्शन ऑडिट करियो पड़िबो टू मेक इट लेजिबल सेथि पे आपण मानको जानिबा दरकार जे व्हाट इज प्रेस्क्रिप्शन ऑडिट एवं से प्रेस्क्रिप्शन ऑडिट संपर्क रे हमें जानिबा एबटू काम आरंभ करबा ताहले वर्ष 2 वर्ष भीतर मध्ये हमें प्रेस्क्रिप्शन को करेक्टली हम जगह दे परबा माने ठीक रे प्रेस्क्रिप्शन लिखबा पे बाध्य होबा हमर सर्विस प्रोवाइडर माने. सो सेथि पे हमें जानिबा जे व्हाट इज प्रेस्क्रिप्शन ऑडिट एवं ऑडिट माने हम समस्त जानते कि ये सिस्टमेटिक रिव्यू analysis and any service is delivered and evaluation in terms of quality within given resources. आम पाखरे जहा रिसोर्स अछि सेवा को नेगिरी आमे ओटे रिव्यू करूचे एवं प्रेस्क्रिप्शन ता ठीक भाव रे लेखा होछि कि नै से विषय जानिबा पे एटा ऑडिट कहंती प्रेस्क्रिप्शन ऑडिट. सो एथिरे मेनली ये पार्ट ऑफ होलिस्टिक क्लिनिकल ऑडिट जहा में हमें जो मुस्कान प्रोग्राम आपण माने समस्त प्राय जानिथिबे सेथिरे हमें ए ऑडिट गोटे पार्ट रखिचे एवं सेथिरे जेतेबेले हम हमर जदी ऑडिट करा जाउची रेगुलरली ताले मध्ये यू विल गेट सम मार्क. So this is a process that the improvement of the patient care and outcome through a systematic review and care against explicit criteria. So ସେଥିପାଇଁ ଆମେ ପ୍ରେସ୍କ୍ରିପସନ ଅଡିଟ୍ କୁ ଏବେ ବେଶୀ ଧ୍ୟାନ ଦଉଛେ ଏବଂ ପ୍ରେସ୍କ୍ରିପସନ ଅଡିଟ୍ କରିବା ପାଇଁ ଆରମ୍ଭ କରୁଛେ କେମିତି ଆମେ ପ୍ରେସ୍କ୍ରିପସନ ଅଡିଟ୍ କୁ ଆମ ଧାରାରେ ପକେଇବା ତେଣୁ ଅବଜେକ୍ଟିଭ ଅଫ କଣ୍ଡକ୍ଟିଂ ପ୍ରେସ୍କ୍ରିପସନ ଅଡିଟ୍ ହେଲା ଆମେ मेनली ସାର୍ ଏବେ ऑलरेडी ଦେଖେଇ ସାରିଲେଣି ତେଣୁ ମୋର ଇଜି ହେଇଯାଉଛି ପ୍ରେସ୍କ୍ରିପସନ ବିଷୟରେ କହିବା ପାଇଁ आमे प्रेस्क्रिप्शन डिटेक्शन करबा जे कोन कोन एरर अछि इट इज नॉट फॉर पोलिसिंग बा आमे एमती पुलिस न जे चोर धरिबा पई बट इट इज पॉलिसिंग माने आमे ताकू रिफाइन करबा एवं बेटर कर परबा आउटकम बेटर हे परबो प्रेस्क्रिप्शन ठीक भाव लेखा जाय परबो तो सेति पई एटा करा जाउची एवं बहुत जगह रे एबे भी आमे देखि छु बळे बळे जेतेबेले आमे जाऊ एसएनसी विजिट रे एवं एसएनसी रे लेखा जाइथिबो डायग्नोसिस थिबो बाथासिक्सिया एवं लेखा दियो एम्पिसिलिन एंटासिस प्रिस्क्राइब कराइ दियो टिकेट रे सो इन व्हिच वे इट इज ऑथेंटिक मु बुझी पारे नै बा एथिकल केमिति आमे हेले सेति में हमकु आपन को के मना करना एंटीबायोटिक लेखिया पई किंतु यू गिव सफिशिएंट रीजन काहे के एंटीबायोटिक रे लेखिले तो सेति में हमकु इरेशनल यूजेस ऑफ एंटीबायोटिक सिरप इंजेक्शन यारो एको अवॉइड करबा पई यूजुअली आमे ए प्रेस्क्रिप्शन ऑडिट करबा पई जाउछे एवं नॉलेज मध्य बढ़िबो धीरे धीरे ग्रेजुअली हमरो सर्विस प्रोवाइडर मेनली डॉक्टर मानकर नॉलेज बढ़िबो ओपीडी रे आईपीडी रे जो प्रेस्क्राइब करछोंदी सेटा को केमदी ऑथेंटिक एथिकली प्रेस्क्राइब करबे एवं माने आमे अन्य मानक द्वारा जेमदी क्रिटिसिज्म रो फेस न करबा then this is the opportunity for improvement of our prescription and good practices को मध्य हमें एमती एग्जांपल देई देखै परबा जे this is a good prescription see how it is rationally prescribed एटा मध्य गुड प्रैक्टिसेस भीतर आसी परबो नेक्स्ट प्री रिक्विजिट्स ऑफ प्रेस्क्रिप्शन ऑडिट रे हमर कोन रहिबो मेनली बहुत जगह अपन माने देखियो हॉस्पिटल मैनेजर माने हमर कोया जाय थाय तांको अपन प्रेस्क्रिप्शन ऑडिट करिवे गोटे क्राइटेरिया रखिवे का कल्प पई बा लक्ष्य पई मुस्कान पई से माने जहा पारती करि दियंती किंतु एमिति अपन मानकु करिवे पड़ो गोटे स्टैंडर्डाइज प्रेस्क्रिप्शन फॉर्मेट रे करिवे पड़ो एसेंशियल मेडिकल लिस्ट अवेलेबल होतबा दरकार सेठी बा हमर जो ईडीएल जोकड़ा हम कहू जे दैट शुड बी अवेलेबल एंड ऑल द सर्विस प्रोवाइडर शुड बी अवेयर अबाउट दिस डिफरेंट लेवल जो माने काम करछोंदी से माने जानिथिबा दरकार जे कोन कोन ड्रग अवेलेबल अछि मोस्टली मु भाउ जे आम स्टेट रे एटा स्ट्रीमलाइन हे जाईची सब पब्लिक हेल्थ फैसिलिटी रे जानिछन समस्त जे आमे को ड्रग आमे प्रिस्क्राइब करबा देन स्टैंडर्ड ट्रीटमेंट गाइडलाइन शुड बी अवेलेबल फॉर ऑल द सर्विस प्रोवाइडर्स एवं एटा मध्य हमर गवर्नमेंट ऑफ इंडिया रो गाइडलाइन सब जाई जे हम जेंति न्यूनाटल पय हम एपीएनसी गाइडलाइन फॉलो करछे चाइल्ड पय एफएमसी गाइडलाइन फॉलो करछे देन एनसीडी रो गाइडलाइन अछि स्वतंत्र भाव रे हाइपरटेंशन और डायबिटीज रे केमते आपण मैनेज करबे कोन कोन ड्रग फर्स्ट लाइन कोन सेकंड लाइन ये सब गुडी को अवेलेबल होता दरकार ताकर नॉलेज रहिता दरकार बिफोर गोइंग फॉर प्रेस्क्रिप्शन ऑडिट So expected outcome कोन ना improving prescription quality at public health facilities mostly हमरो CHC SDH DHH रे जते प्रेस्क्राइब करूचे हमें से हेल्थ फैसिलिटी रो प्रेस्क्रिप्शन टारे क्वालिटी इंप्रूव करबो रैशनल यूज ऑफ ड्रग्स हमें देखिबा गोटे गोटे प्रेस्क्रिप्शन रे 10 टा ड्रग 5 टा ड्रग लिखा जाय दिबो तो एक्चुअली सब ड्रग दरकार कि नाही एटा मध्ये हमें जानिथिबा दरकार then automatically that will reduce the cost of the treatment by reducing the unnecessary prescription एवं जेनेरिक मेडिसिन को हमको लिखिबा पय हमको कहा जाउची we have to write the generic medicine name in the prescription एई प्रेस्क्रिप्शन ऑडिट को माने फेस करिवे बा काहर प्रेस्क्रिप्शन को ऑडिट करा जाय परिबो से माने हेले एई हॉस्पिटल ले काम करथिबा हमरो डॉक्टर माने जो माने कि डिस्ट्रिक्ट हॉस्पिटल एसडीएच सीएचसी पीएचसी रे काम करचंदी एलोपैथिक डॉक्टर माने एमानकर प्रेस्क्रिप्शन ऑडिट करा जाय पारे केते बेले भी कोनोसी मेडिकल कॉलेज मध्ये एटा को टेक अप कर जाय पारे जे हमें एई जिल्ला रो प्रेस्क्रिप्शन ऑडिट करिया में चाहूछु एवं एथिकल कमिटी रो क्लियरेंस करे दे आर एलिजिबल फॉर प्रेस्क्रिप्शन ऑडिट एवं वर्तमान हमरो प्रेस्क्रिप्शन गुडी को सब रहूची फार्मासिस्ट मानो पाखरे होते स्कैन कॉपी एवं से स्कैन कॉपी रो से माने रैंडमली सिलेक्ट कर परिबे एवं सेटा को आपण प्रेस्क्रिप्शन ऑडिट कर परिबे एवं निज हॉस्पिटल में मध्य हमर एडमिनिस्ट्रेटर माने एई प्रेस्क्रिप्शन ऑडिट को प्राधान्य दे परिबे एवं कर परिबे एंड आ गोटे जिनस होची आमे मेनली आमे एटा मेडिकल लीगल केस को इंक्लूड करू ना एथरे जो प्रेस्क्रिप्शन होची सेडा एथरे आसुनी सो तो these are all components तेनु हमको मेडिकल ऑडिट बा मेडिकल प्रेस्क्रिप्शन ऑडिट हम डीएमओ होंतु बा सुपरिटेंडेंट होंतु सेथिरो से माने मध्य कर परिबे नेक्स्ट मेथोडोलॉजी विषय टी खाली म कहि दोची मेथोडोलॉजी रे आमे कोन मिसेस भार म कहली इट इज नॉट फॉल्ट फाइंडिंग इट इज फैक्ट फाइंडिंग कोन प्रकृत रे करबा कथा एवं कोन होची इट इज नॉट पॉलिशिंग वी आर डूइंग पॉलिशिंग ऑफ द प्रेस्क्रिप्शन एंड इट इज एन इंटरनल मेकानिज्म फॉर क्वालिटी इंप्रूवमेंट पांच जन डाक्टर जदी सीएचसी रे अछंती से मानक भीतर प्रेस्क्रिप्शन ऑडिट करे आमे गोटे मीटिंग करिग्री सेठी मध्ये आमे डिस्कस कर परबा एवं फर्दर आमे एडवाइस दे परबा जे हाउ टू improve our prescription process एवं दिस इज द विशियस साइकिल जो थरे कि आमे फ्लो चार्ट हिसाब रे आमे केमती ए साइक्लिकल प्रोसेस को कंप्लीट करबा प्रॉब्लम जानिले तापरे क्राइटेरिया एग्रीड हबो मीटिंग रे एवं तापरे ऑडिट डाटा कलेक्शन हबो एनालिसिस हबो एवं तापरे मेक नेसेसरी चेंजेस एवं सेही मेथोडोलॉजी विषय रे मुके एठी कहबा पई चाहू so this is of course same algorithm जो थरे कि आमे प्रेस्क्रिप्शन ऑडिट करबा पई जाउछे एठी गोटे जिंस होची आमे जति कि आम इंस्टीट्यूशन रो प्रेस्क्रिप्शन बाहरची तार गोटे सैंपल साइज हम नबाक पड़िबो एवं सैंपल साइज रो फॉर्मेट मध्ये देखै देबी केते ओपीडी पेशेंट आसुले आपण केते सैंपल लेबे तार डाटा कलेक्शन रो फॉर्मेट रे डाटा कलेक्ट करबे देन एनालिसिस करबे डाटा देन को कंपोनेंट रे लो स्कोरिंग अछि जेटा देखिबे तापरे इंप्रूवमेंट पे प्लान करबे नेक्स्ट दिस इज फास्ट आपण माने ऑडिट कमिटी करबे गोटे हॉस्पिटल रे जदी आपण प्रेस्क्रिप्शन ऑडिट करिया पे जाउचंदी ताले सेठी मेडिसिन एंड थेराप्यूटिक कमिटी नारे गोटे कमिटी करिवे एवं सेतिरे मेनली को माने रहिबे सजेस्टेड मेंबर्स हेले हॉस्पिटल इंचार्ज जदी डीएचएस बा एसटीएच रे कहउचंदी हॉस्पिटल इंचार्ज बा सीएमओ देन हॉस्पिटल एडमिनिस्ट्रेटर जदी अछंदी से रहिबे वन क्लिनिशियन फ्रॉम ईच डिपार्टमेंट इंचार्ज नर्सिंग ऑफिसर एंड चीफ फार्मासिस्ट तो ए माने होचंदी मेंबर इन द ऑडिट कमिटी सेमान को लेके आपण गोटे कमिटी करिवे नेक्स्ट फॉर्मुलेट करबा परे देन जदी आपण सीएच रे करबे चाहजंदी ताले मेडिकल ऑफिसर फार्मासिस्ट एवं गोटे जने सीनियर नर्स मध्ये आपण नेगिरी ए ऑडिट कमिटी कर परबे specific details like antibiotics prescribed medicines prescribed as a standard treatment guideline can be audited through the peer review by another medical officer माने जनकर प्रेस्क्रिप्शन आ जने मध्ये रिव्यू कर परबे एवं तांकु सेठी सजेशन दे परबे so scan copy of minimum 30 prescription can be sent to district quality assurance unit for review जहा को आपण कले तादरु 30 टा मध्ये आपण डिस्ट्रिक्ट को पठे परबे indicator to check the completeness of the prescription patient details name age sex address ये सब जिंस रहिबो chief complaint diagnosis medicine information non pharmacological treatment description then signature अछि ना नै सेटा देखिबे एवं तार परसेंटेज केमति बाहर करिवे सेटा को हमें देखिबा परसेंटेज ऑफ प्रेस्क्रिप्शन विथ लेजिबल हैंडराइटिंग prescription where medicines prescribed in standard treatment guideline as per standard treatment guideline then allergy mention है ना नहीं prescription with a brief history अछि ना नहीं provisional or final diagnosis then silent features of clinical examinations are recorded and prescription where scheduled dose and drugs are written तो तापरे को केतेटा परसेंटेज ऑफ प्रेस्क्रिप्शन रे विटामिन टॉनिक एंजाइम लिखाइ जे सेटा को मधो एनालिसिस हमें करबे सो स्टेप 2 रे कैलकुलेट सैंपल साइज केने हमें सैंपल साइज जो जानिबा हमहु इजी हे जे परबो ये सब होला फार्मूला किंतु मु आपन को पूरा डायरेक्ट सैंपल साइज रे हिसाब देखै दोची नेक्स्ट स्लाइड रे दिस इज सैंपल साइज माने करो गोटे ओपीडी रे अटेंडेंस होची 10 टी ताले सेठी 9 टी सैंपल को नबाक पड़िबो 9 टी प्रेस्क्रिप्शन नबाक पड़िबो सेमिति जदी 500 होची गोटे जगह रे ताले 81 टा सैंपल नेले प्रेस्क्रिप्शन नेले ताको आपन गोटे माने एडिक्वेट सैंपल साइज हैला बोली जणा पड़िबो 300 रे 73 200 रे 66 प्रेस्क्रिप्शन एमती करिकरी हमें सैंपल साइज कैलकुलेट कर परबा एवं सेति की सैंपल प्रेस्क्रिप्शन देकी हमें ऑडिट कर परबा तापरे असला डाटा कलेक्शन एवं डाटा कलेक्शन पई हमें जो सैंपल नउचे टाइम पीरियड भी नै गेले कैलकुलेशन कर देले हाफ ऑफ द सैंपल शुड बी टेकन इन द फर्स्ट 2 वीक्स एंड नेक्स्ट हाफ इन द रिमेनिंग 2 वीक्स रे नबा एवं समस्त जन को दायित्व देबाक पड़िबो इधर फार्मासिस्ट नर्सिंग ऑफिसर और हॉस्पिटल मैनेजर जे की कलेक्ट करिवे ई प्रेस्क्रिप्शन को तापरे स्टैंडर्डाइज फॉर्मेट कैन बी यूज्ड फॉर डाटा कलेक्शन एवं से कलेक्शन रो डाटा हमर गोटे गाइडलाइन अछि पर एबे गवर्नमेंट ऑफ इंडिया शेयर करछि प्रेसिजन ऑडिट पई सेतिरे एनेक्सर डी रे अछि फॉर्मेट केमति आपण माने डाटा कलेक्शन करिवे से विषय रे मु तार जस्ट एक एग्जांपल आपण को एठी देबी नेक्स्ट एटा होछि क्राइटेरिया ओपीडी रजिस्ट्रेशन नंबर मेंशन हेछि ना नाही कंप्लीट नेम ऑफ द पेशेंट लिखा है ना नहीं एज जदि 5 वर्ष अधिक अछि लिखा है इन केस ऑफ लेस देन 5 इयर्स मंथ रे लिखा है नहीं ओजन लिखा है ना नहीं दैट टू पुनी पेडियाट्रिक एज ग्रुप जदि अछि ताले सेथिरे आपनकर न्यूबॉर्न रे ग्राम्स रे लिखा है ना नहीं एवं पॉइंट रे लिखा है ना नहीं बड़ पिलांगर ए सब जिंस सेथिरे रहइबो then that date of consultation केबे हितला gender of the patient handwriting is legible or not brief history written or not allergy status mentioned or not ये सब कंपोनेंट्स रही 26 टा कंपोनेंट ये 26 टा कंपोनेंट ऊपर हमको एनालिसिस करय पड़िबो एवं से अनुसार हमें प्रेसिजन को ऑडिट करिया पई रेडी कर करिया so these are all components जहा ऊपर हमें चेकलिस्ट तैयार करिकरी प्रेस्क्रिप्शन को केते पर्यंत एलिजिबल अछि सेटा को हमें असेस करिया नेक्स्ट तापर असला स्टेप 4 डाटा एनालिसिस एवं डाटा एनालिसिस बेल को हमको आ गोटे फॉर्मेट तैयार करि पड़िबो एक्सेल शीट करिया पड़िबो एवं से एक्सेल शीट रे मेनली हमको यस नो जो जो कंपोनेंट 26 टा कंपोनेंट रहिला से कंपोनेंट रे यस नो रे ही हमें ताको आंसर लिखिबा एवं एक्सेल शीट रे से हिसाब रे यस रे 26 टा कंपोनेंट रे केतेटा यस आ केतेटा नो पडिबो ता धरे प्रति कंपोनेंट को हम असेस करबा एवं कंपोनेंट वाइज कोथरे परसेंटेज कम रहउची सेटा को देखा जिवो सो दैट इज द मेन अनदर एग्जांपल मु से दोजी नेक्स्ट एटा देखंदु डाटा एनालिसिस एंड कैलकुलेशन केमती करा जायछि P1 P5 माने प्रेस्क्रिप्शन 1 टू 5 एवं एठी ओपीडी रजिस्ट्रेशन नंबर मेंशन हेछि ना नाही सबुथरे हेछि ताले यस पडला सो 100% प्रेस्क्रिप्शन रे आसीबो ओपीडी रजिस्ट्रेशन नंबर मेंशन कंप्लीट नेम ऑफ द पेशेंट इज रिटन और नॉट एथरे जदी गोटे नाही ताले से हिसाब रे परसेंटेज आसी जिवो यस यस नो यस सेमती एज कथा जेंति कहली सो ये क्राइटेरिया सब लिखा है से प्रेस्क्रिप्शन ऑडिट रे एवं से हिसाब रे हमें प्रेस्क्रिप्शन ऑडिट को एई फॉर्मेट रे पक्के करबा एवं फॉर्मेट अनुसार एनालिसिस मध्य कर परबा इट इज वेरी इजी टू एनालाइज द थिंग्स सेमती डाटा एनालिसिस करबा परे हमें परसेंटेज कैलकुलेशन करबा केते केते रु केते परसेंट ठीक अछि केते रु कोथरे कम परसेंटेज अछि केते कोट बेसी अछि अगेन क्वालिटी साइकिल को जदी हमें आसीबा पीडीसीए साइकिल अनुसार क्वालिटी प्रेस्क्रिप्शन ऑडिट को हम इंप्रूव करबा पई के रूट कॉज एनालिसिस करले तापर डेवलप करे पई बाउंड टाइम बाउंड एक्शन प्लान करबा देन फाइंडिंग को शेयर करबा इंप्रूव करबा पई पीडीसीए साइकिल यूज करबा तापर से इंप्रूवमेंट को केमती सस्टेन करबा एटा को हमें कर परबा सो फॉलो अप ऑडिट मध्ये हम कर परबा थरे हम जदी टेक अप करले एटा को गोटे डाटा कैप्चर करी कले प्रोजेक्ट हिसाब रे ताले टाइम लाइन परे इंप्रूव कला कि नाही केते इंप्रूव कला एवं आउ केते इंप्रूव कर परबो सेटा मध्ये हमें एनालिसिस करी तांगु देखे करबा सो दिस इज ऑल अबाउट प्रेस्क्रिप्शन ऑडिट मु आशा करिवे एटा बेसी बेनिफिटेड हो फॉर द डीएमओ आ सुपरिटेंडेंट मानकु एवं प्रेस्क्रिप्शन ठीक भाव रे हम केमती करै परिबा ऑडिट करी रैशनल यूज ऑफ मेडिसिन्स करि परबा एवं प्रेस्क्रिप्शन ठीक भाव रे लिखै परबा दिस इज जस्ट एन गोटे ओवरव्यू मु सेति पे समस्त को धन्यवाद देबी जे आपण माने समस्त सुनिले एते समय तो नाउ टाइम फॉर क्वेश्चन आंसर मु भाबुची डॉक्टर एनबी दास क्वेश्चन पचारथि होदे
गोटे टॉपिक अछि ना डॉक्टर मीनाश हमरो
हां मु आसीची मैडम हां सर okay now Meena madam is there Meena madam can you talk in the next topic okay
Good evening. Thank you so much. I really appreciate the directorate and the leadership of Dr. Aditya sir for taking this forward and also to discuss on such an important topic. I respected ADCH, respected DFW, Dr. Bhuya sir, Dr. Ram Kumar and Dr. Mishra sir. This topic of antibiotic resistance and antimicrobial policy is a very important area. As we proceed, as we progress, there is a increasing incidence of antimicrobial resistance or antibiotic resistance, what we are seeing across, not only in children, but also among adults. And infections occurring in the mother and neonates, they are exerting a substantial health burden. And antibiotics have been a miracle discovery. Antibiotics save lives. However, when the usage of antibiotics are not needed, we are using antibiotics when not needed, this is leading to the emergence of antibiotic resistance. And this is one of the biggest threats to global health. And this is leading to longer hospital stays, higher medical costs, more deaths, etc. So optimizing infection management is crucial for improving the individual outcomes. As the previous speakers have already highlighted, it is very important as to how is that we manage, we follow the standard treatment guidelines, what is to be done. It is not necessarily important that all babies in the SNCU should be receiving antibiotics. So these are important for reducing the incidence of antimicrobial resistance. And it is a group effort. All of us need to work together. It is not only the effort of only one person. The healthcare professionals, policymakers, all the stakeholders, starting from the support staff in the units, everybody has a role to play. And this improvement needs to be done not only in the SNCUs but also in the labor rooms. So both the areas, we need to ensure that the BMW protocols are followed, hand washing and antisepsis techniques are well taken up. Fishbone analysis can be done for all the units, including labor rooms, followed by PDSA cycles. Earlier, Odisha had a good practice of taking up small POKI projects. So this is something which we can again start as a key activity, quality assurance. Each of the SNCUs can actually take up some of these POKI projects, and one of the topics could be to reduce the antibiotic usage. UNICEF will continue to provide technical supports towards the improvement of quality care for the newborn and also for newer initiatives like the MNCUs, the mother newborn units, and also strengthening the KMC, IKMC, and all of the new initiatives. I again appreciate and thank the role of the department in taking up these initiatives and taking the leadership for ensuring not only survival but also intact survival, because we are not only talking of survival alone. Though Odisha has a high newborn mortality rate, we are talking of intact survival, and we should address the other important areas like birth asphyxia. So thank you so much for giving this opportunity and also taking forward these initiatives of improving the capacities of the staff. Thank you. Thank you.
अच्छा मधुस्मिता मैडम रेज हैंड करूथले किछि कहिबे कि आपण जदि कहिबे हम आपन अलाउ कर दउ नाले क्वेश्चन आंसर सेशन रे किछि लेखन चार्ट रे if you are not raising hand accidentally. भुया सर कोन कहिबे कि आपण भी रेज करछन हैंड
हाँ मुझे पचार आर्थले आपनको
हां सर कोन
actually जो topic मु presentation कली actually many of the answers I got from your talk actually.
सर
So what you presented is actually, is it being done in our state? This audit of prescription?
this
Has it
is
started?
is a guideline I have shared from Government of India.
Oh, it is not started. If it can be started actually in a real sense, it will go a long way in improving the rational prescription and legibility of prescription.
Actually, sir, we are doing many quality improvement activities in the facility, like Kayakalpa, Muskan, Lakshya programs. They have got many checklists, and in those checklists, one of the component is prescription audit. If they have done prescription audit, then they will get 2 marks. If they will not get, they have not done any prescription audit, then they will get 0 marks. So
this can be compiled and presented, no? Like
yes.
I quoted the ICMR study when they have made a prescription audit and found out. Similarly, if we can make a prescription audit and present a presentation after 1 year, actually you know what is happening in our state. Actually.
This is something, sir, internal quality improvement. On their own, they can do it. But externally also, somebody can do. Suppose IAP, Indian Academy of Pediatrics, wants to do prescription audit, they can apply to the mission director and clear the ethical committee, and you will also be allowed for the precision audit for few districts or few facilities. That can be possible.
No,
But
this audit should involve all specialties of medicine, and whatever you presented, the steps you presented, that involves everybody equally. At government level, this can be done.
yes, sir.
The results can be found out equally.
Thank you, sir. Dharmangad, SDS Dharmangad. Hello, Dharmangad, SDS, do you want to say anything? No. Okay, so we don't have any more questions. One question was there from NB Das. I have answered it. Actually, CRP 10 milligram per liter or 1 milligram per deciliter. Second thing is about how to clean mobile. It is better that mobile companies can tell how to clean mobile, but we can restrict our mobile entry into the critical care units.
Sir, actually mobiles ପାଇଁ actually ଆମର जो transparent covid time रे sir ଆମର ଗୋଟେ से जो ziploc bags आसे sir ziploc bags ଭିତରେ ରଖନ୍ତି and they are disposable, so they can be kept. And one and number two sir तार ଗୋଟେ spray आସୁଛି sir, spray आସୁଛି, spray clean କରିବା ପାଇଁ ସେଟା can be used.
Yes.
ଗୋଟେ spray ଅଛି sir electronics ପାଇଁ.
Another question is there from GPS Mishra. Amoxicillin doses for more than 7 days baby 30 milligram per dose or per day for pneumonia treatment.
Sir, IMNCI हिसाब रे 0 to 7 days पर्यंत तो सेटा तो नहीं, 7 days रू 2 months पर्यंत it is 30 mg per kg per dose BD for 7 days. एटा होची निमोनिया पई एटा डोज टा IMNCI रे दियाइछ. आउ अन्य कॉजेस रे किंबा 2 months रू 5 years रे जो डोज टा अछि सेटा 25 mg per kg per dose BD for 5 days.
Yes, sir. GPSY, you can go through the SANS guideline which was supplied by Government of India. I think it was shared with all the districts. So you should have this guideline in your OPD, and if you will go through that, you will get your answer. That is correct from Ram Kumar sir. Next is respiration rate more than 60 per minute. It is pneumonia. Is it pneumonia?
Respiratory rate more than 60 if mane especially less than 2 months thore hella pare second time you have to count and the second count is final. If it is more than 60 for community level it is classified as pneumonia in the absence of severe chest indrawing. But if it is less than 7 days, any tachypnea more than 60, then it indicates whether it is a possible serious bacterial infection or it is a very severe disease. Seti kichi pneumonia or term nahi less than 7 days. So because this guideline is being issued for the IMNCI, seti tanko pai a terminology use କରାଯାଇଛି. तो if at all like ଆପଣଙ୍କୁ ପଚାର ଆପଣ there is a point that ki probably more than 7 days baby more than 60 ହେଲା IMNC ହିସାବରେ pneumonia ରେ classify କରାଯାଇଛି, baby ଟାର pneumonia ରେ heart disease ହେଇପାରେ. So yes possibly, so more than 60 ହେଇଗଲା ତାର ଅନ୍ୟତମ ଆଉ କିଛି ସାଇନ୍ ଆସି ଯାଇଥିବ କିମ୍ବା ଆମେ ଯଦି 48 hours ଭିତରେ ଆମେ ତାକୁ ଯୋଉ ଡାକୁଛୁ, even if the baby is not improving, we will call in 48 hours as per the program. So or earlier if other danger signs appear. So ଆମକୁ ଆଉ କିଛି ଆସିଲା ତାହେଲେ ତାକୁ ଆଉ କିଛି ଇନଫେକ୍ସନ କଣ ଭାବିକି ଆମେ ଆଣ୍ଟିବାୟୋଟିକ ଦେଇକି ଆମେ ରେଫର କରିଦେଇ ପାରିବା, ଯୋଉଠି ଯିବ ସେଇଠି ତାଙ୍କର କମ୍ପ୍ଲିଟ ଇଭାଲୁଏସନ ହବ as per the program.
Yes, thank you. Actually ଏଠି ମୁଁ intimate ମାନେ ସମସ୍ତଙ୍କୁ ଜଣାଇବାକୁ ଚାହୁଁଛି ଆମେ pneumonia possible serious bacterial infection even within less than 2 months ରେ ଯଦି ଆମେ ପାଉଛେ, ଯାହା ବି ରାମକୁମାର ସାର୍ ଦେଖେଇଲେ any sign ଆପଣ ପାଉଛନ୍ତି ତାକୁ ଆପଣ possible serious bacterial infection ହିସାବରେ ରିପୋର୍ଟ କରିପାରିବେ, କିଛି ଅସୁବିଧା ନାହିଁ. କିନ୍ତୁ provided you have to count the respiration for 1 minute, not that 15 second count କରିକି 4 ରେ ଗୁଣିବେ. Another question is there, in spite of so many improvement in neonatal care, what are most common neonatal death causes in our state? Actually, again, it varies from causes to causes. Agur jodi ame dekhiba, sepsis was common cause. Bartaman birth asphyxia is most common cause, which is preventable also. Tenu bartaman ame essential ro data ku dekhi ki analysis kari jani paruchu je amar koti na koti ame gap mane kiछि gap rohuchi amar service provision re, because on an average nationally ame dekhilu 18 ru 19% birth asphyxia admission in essential, whereas amar 25 ରୁ 30% होची on an average, किंतु district wise जे देखिबा 40% admission ମଧ୍ୟ होची. So एठी लेबर रूम रो गैप रहिची, लेबर रूम रो कॉन्फिडेंस बिल्डिंग होउनी स्टाफ मानकर जा फल कि बाथ शिक्षा अधिक आसुची. So now this is the high time to think about that. एबे recently Tamil Nadu रो presentation होतला जोथरे कि essential admission होचंदी more than 90% are preterm and LBW babies. तो सेप्सिस आउ बाथ asphyxia पूरा कम तांकर. तेनु सेया को हमको आख्या के रखियो पड़िबो. ए जो इन्फेक्शन प्रिवेंशन कथा कहला, it is also applicable for labor room, also applicable for the postnatal ward if you want we want to prevent sepsis and bath asphyxia. So bath asphyxia to confidence building of the nursing officers in labor room is a must. सेटा जदी करिबा ताला हमर बाथ asphyxia रो एडमिशन भी कमी जिवो, प्रिवेंशन कर करबा. So I think there is no more question. Panelist को बहुत धन्यवाद. सर आप किसी ऐड करिवे विजय सर?
Actually बहुत भला हला. It is a very well organized and it has gone without flaw, and every teaching is a learning experience for everybody who are present. So such programs should be there in future to do mass education of people involved in the care of the newborn babies for better newborn survival and intact survival. Very important and valid points have been told by all the speakers, and Ram Kumar has told excellent, and he has touched all practical aspects of this use of antibiotics in newborn. He has told very well, and Meena Madam has also summarized everything in a very nice way, and Dr. Bhuya has also highlighted the importance of prescription audit, and you are the right person to start the program of prescription audit in our state. So I think you yourself with UNICEF should take up the project. I remember 25 years back, I presented a paper on prescription audit from a tertiary care hospital in the East Zone conference, and it created a lot of highlights and sensation among all, like Bhuya sir depicted today. So there is a need for prescription audit and correcting our own mistakes, which is done at our level.
Yes, yes, very nice.
राम कुमार किछि कहबे?
Kwedi Chand sir, thank you sir for the kind words.
What is the definition of bath asphyxia practically? Practically is if the baby is not crying after bath. That is simple. No, there is no complicated definition. Meena madam, any final conclusion?
So jodi pravak jodi se jo birth asphyxia कहउचंती, what is the definition of birth asphyxia? So birth asphyxia is actually inability to initiate spontaneous breathing at birth is called as birth asphyxia. तो एटा होची हमरो माने definition गोटे, but as and जेमती जेमती हमरो level बढ़िबो तारो definitely blood gas sangre, cord blood sangre बहुत किछि definitions अछि. For the different studies ପାଇଁ सेटा include hobo. The only one thing, one message to be given is that there is an entity called as perinatal depression. So सोतरे कि पिलाटा due to some reason baby is माने initiate करला परे किंबा initiate करनथियो टिके समय ପାଇଁ for few hours baby will be very looking very sick, but after that baby completely recovers and the baby has no other signs of HI. So this entity is called as perinatal depression, and it needs to be differentiated from HI because perinatal depression ro prognosis ta otherwise is much better compared to the other serious forms of HIV.
डॉक्टर आचार्य का क्वेश्चन हला मैट्रेस रे कोना हले सेटा किंती इन्फेक्शन होबनी हबो तेनु मैट्रेस को किंती हमें पैच करबा तार व्यवस्था मते करा जाई छी सो हॉस्पिटल मैनेजर शुड टेक द इनिशिएटिव एवं हाउ टू रिपेयर दोज मैट्रेसेस ओके मीना मैडम फाइनल वर्ड okay so I think this is the time to close this session मु बहुत धन्यवाद देबी प्रभाकर सर को विजय सर को एवं राम कुमार सर को पर नाइस डेलिब्रेशन एवं
मोर मेबी टॉप रे सरिला
आपण माने एक्सप्लेन कर परले एवं आगो को मध्य मु भाबु जे एभली सेशन रखिबा एवरी मंथ हमें एटलीस्ट गोटे रखिबा 2 घंटा पई जा फल कि हमर सर्विस प्रोवाइडर माने बेनिफिटेड हेबे एवं समस्त को धन्यवाद एवं नमस्कार आमे एबे लीव करछु थैंक यू
Thank you.